Can you hear me okay? All right, so that's John Massey. I'm Todd Stull. We appreciate the opportunity to be here today and talk about some different topics related to getting the waiver. These will be recorded. So some of the information we're going to be covering and the details you'll see on the slides, you'll have access to them because we may not go point by point, but more depending on the slide, overall gestalt. We will start with alcohol, and then we'll move into opiates and pain, and then we will move into nicotine and tobacco and marijuana. Part of the reason we chose what we did is we've done so much over time with opioid use disorder and buprenorphine and treatment for opioid use disorder, not only kind of how to recognize it and treat it. We felt like we needed to extend beyond that into the practical value of what do what usually kind of comes into a clinic, what kinds of problems related to substance use and pain and so on. So there'll be some case examples today, not as much in my part, and we kind of go back and forth with this. But there hopefully will be practical applications. If you look at Nebraska and the state of Nebraska and what you see in terms of individuals that have substance use disorders, it's alcohol, tobacco, marijuana, methamphetamine, and then kind of opiates. So it's not to say opiates aren't a problem. Part of the reason opiates have gotten so much attention is the settlements and the settlement agreements with all the distributors and manufacturers from those companies that make opiates. And there are three really substance use disorders that we have evidence-based treatment for from a pharmacological aspect: nicotine, alcohol, and opioid use disorders. So that's why the opiate use has gotten so much trouble with this, or I'm sorry, so much press and with the settlements. Now, let's change gears a little bit because I want you to be aware of, in the state of Nebraska, we have an opioid advisory committee. John and I are fortunate to be on that. And the settlement dollars that are coming into the state of Nebraska are $150 million over the next 18 years to be used to treat a range of things that are either directly opiate related or ancillary to that. So it could be law enforcement issues, it could be newborn issues, or mother-child kind of issues. It could be education, it could be treatment, it could be comorbidity. So there's a range of things that can be used, and this committee is kind of working with the state and the regions and the Attorney General's office, as well as the Department of Health and Human Services, to try to use some of these funds to provide services in the state of Nebraska. So I wanted you to be aware of the potential for kind of some of the treatment options that are going on. So let's dig in, and if there's points or questions along the way or things that need to be clarified, please let me know. We want to make this as practical as possible, but also introduce some important things to you. When we think about medical education across the spectrum, there's very limited amounts that are devoted to over time, and especially from some of the older providers, like John and myself, right? We didn't get much in terms of addiction and pain and management of pain and addiction and substance use problems. So we want to try to fill some of those gaps because these problems are so common. And when you talk about someone who has, and I'm going to share some kind of overall concepts with you as we move in here that are take-home points to remember to think about when someone has a substance use disorder or a mental illness or psychiatric illness and pain. Those three overlap an awful lot. So let's move ahead. Carl Jung was a psychiatrist in the day of imposter syndrome. This kind of resonates with some people. All right, we're going to talk about background. We're going to talk a little bit about intoxication and withdrawal. Not a whole lot, because I think that's probably something that's more familiar with most. We're going to review kind of some of the data and what to think about the data, and then discuss treatment options. So in any given time over the last, I suppose 10, 15 years, you can think of about 20% of the population having a mental illness, and about 15% of the population has a substance use disorder. So look at the top of that screen, if you will. And within that, we've been we always say, oh, substance use disorders are diseases. Let's don't get caught up in that so much, whether you believe that or not. Let's focus on more the nature of what happens over time with someone who has a substance use disorder. And you will hear, for example, from AA and other organizations or other people in the substance world that work in that world, substance use disorders are chronic relapsing conditions. That's not true. So I want you to recognize that. It is true in some cases, but the majority of cases are not chronic and they're not relapsing. So 93% of individuals with a substance use disorder don't get treatment. 70% of those, of that group who doesn't have treatment gets better on their own with no intervention, no treatment at all. So we have this notion that somebody's got a substance use disorder, oh, they need treatment. And that's just not the case. So we're each going to be talking from our kind of perspective. John is an anesthesiologist who does pain. I'm a psychiatrist that does a lot in this substance use world. Another take-home point, or series of points. Someone who has a substance use disorder, the more severe it is, the more likely they're going to have other comorbidities, whether they're medical problems or psychiatric problems. So for that group that's more severe within the substance use spectrum, about 50% of them will have a psychiatric illness. Half of them will have a mental illness. If you go the other way and say, how about somebody who has a mental illness, what percentage of them have a substance use disorder, nicotine being the most common? About 30% of those individuals will have a substance use disorder that has a psychiatric illness. So what determines outcomes for someone who has a substance use disorder? Commitment to their kind of whatever plan they have to either reduce the use of their substance or become abstinent, or in recovery. Recovery is kind of a slippery term. Or, in addition, treating mental illness. Untreated psychiatric illness relapse rates are much higher. Okay. The third thing is replacement behaviors or activities. Really important. So what am I going to do instead of come home and have a cocktail in the evening, or go to the bar, or associate what I'm doing with my drinking or my substance use? So replacement behaviors and activities. And the fourth is your network, the group that loves you, holds you accountable, and doesn't make you feel punished or humiliated or ashamed, but is brought along with you to be supportive. So those four things: working in some type of program, treatment of psychiatric or mental illness, network, and replacement behaviors are key elements to outcomes. So I've already mentioned this. This is a little bit of a busy slide. Look at the red line in particular here, and you will see over time, this is 20 years, the majority of people who do not have treatment for a substance use disorder get better on their own. Then there's that population kind of in the blue and in the pink that don't stop, but their condition or situation is more manageable. So it's only a small percent, which you will see, that it's a problem. Now, let's look at some other data that's kind of important, because people always say, well, what's the most addictive substances? Addictive substances are determined by a number of variables, so it's multifactorial, all the way from genetic influences and cultural influences, but two big things that really stick out. And I'm going to cover two here, and I'm going to follow up with four. Two things that really stick out are how quick it gets into the system. Okay, so smoking or injection, right? And how much euphoria it causes. And so we always associate euphoria with dopamine, which is not, you'll see as we go through this, that's very kind of reductionistic. It's much more than dopamine. And so how quick it gets in and the euphoria. Now, genetics plays a big role. And what does genetics influence when it comes to this? Huge component of kind of influence comes from tolerance. So you'll find people that have higher tolerances, there is a strong kind of genetic load, right? The euphoria that goes with it, largely genetically determined. Stimulation is another one. It's the third thing to think about. So, and then people in the case of alcohol, the other genetically loaded influence are those people that don't have much in terms of hangover or withdrawal. They're wired differently. So those four characteristics are largely genetically influenced and predispose somebody to having problems. So the average person that drinks alcohol, if they have 5 drinks of alcohol, they get kind of sluggish and tired and worn out. The person who has that genetic loading, they're excited, they're ready to go. They respond differently. That group often is the ones who will drink 8 to 10 or 12 before they start to feel the effects, but versus that group that drinks 5 and they're kind of ready to take a nap or sleep or what have you. So there is a difference when it comes to genetic load. That's true not only of alcohol, but other substances. So when you look at the addiction liability, part of the reason we're talking about nicotine is this up at the top, you know, and the number of people that are affected by tobacco. Heroin may be replaced by fentanyl and carfentanil. We'll see over time. That was not included in this study. And then you can work your way kind of down the list here. You can see alcohol is up there as well. How about when we look at the blue here of a given substance, and the blue is harm to the individual who's using. This is on an index score of 100 from this study that was in the Lancet. And the orange is harm to others. What substances cause the most harm to the individuals and to others? Well, you can see at the top is alcohol, and tobacco is not too far down. And these are 2 we're going to be talking about in addition to the opiates. So I just want to give you a little background before we move into alcohol and kind of what to think about. It comes from kind of a 800 CE with the Arabs and capturing kind of the spirit, if you will. So something subtle as they started to manufacture or make it through a fermentation process. And we're not going to go through the details of that, but through the basic kind of, when you take it in, hits the GI tract, right? And some of the enzymes are in the stomach. Most of the absorption is in the first part of the small intestine. Foods affect absorption as well as the enzymes that we're going to kind of cover a little bit here. Building up in your system causes nausea and headaches and dizziness and diarrhea and those sorts of things. People don't like that effect. So they're less prone to having a drinking problem. Now, let's go back to something I said earlier on, and what happens when someone ingests alcohol. It's not just going straight to dopamine. Dopamine is connected to the opioid receptors. So when we get into some of the treatments about alcohol use disorder, they actually affect the opiate receptors primarily, or some of them do, not all. So when you drink alcohol, you get a stimulation of the opiate receptors, almost like, you know, in a sense, similar to taking an opioid, like morphine or oxy or what have you. Then what happens is that downstream effect, you get an increase in glutamate, and you get also an increase in dopamine. Well, dopamine is the euphoria, I feel good. The excitation, energizing effect early on, if you don't take too much or drink too much alcohol, comes from glutamate. So glutamate, in essence, in high amounts is neurotoxic. Let's go back. I want to give you an example of glutamate. Let's go back about 10 to 15 years ago. You may remember outside of Omaha, made the news. There was a young couple in the winter that was walking around, and it was in a snowstorm below zero, and they had been using methamphetamine. And that methamphetamine, when you use methamphetamine, it really increases dopamine levels. But the other thing it does is it increases glutamate. Glutamate is excitatory. It's neurotoxic at high amounts, so people do strange things. So for a meth user, when they're high on meth, when they're using a lot of it, and over time, not only will they be sleep deprived, but they'll do things like what's called geeking and getting spun out. They will walk the same aisle of Walmart for hours and hours and hours. They'll pick their toenails for hours and hours and hours. Well, this young couple walked right by a heated pump house that was unlocked and didn't open the door and they died, right? Because of the neurotoxic effects of methamphetamine impairing one's ability to make decisions or do things that would make sense or you would check on if you were in that scenario. So glutamate's excitatory. GABA slows the world down. GABA is a relaxer. GABA is benzodiazepines, if you think about it. It's the Xanax, it's the Valiums, it's the things that kind of take the edge off of anxiety or worry and has muscle relaxant properties and so on. All right, so what happens when someone starts drinking and they just initiate the drinking? And the take-home point from this slide is that as drinking progresses, and I said this earlier a little bit in a different way, it becomes more genetically loaded. Those individuals that have a higher genetic load for tolerance, avoidance of withdrawal symptoms, the excitation, and the euphoria, that's the group that's at higher risk for a substance use disorder. That's the group that's at higher risk for an alcohol problem, for a methamphetamine problem, for a opiate problem, or what have you. Low levels, buzz, euphoria, kind of relaxed. As we get into the kind of 0.1 level of grams per deciliter, you get into a little bit of impairment with speech, slowed reflexes, slowed decision-making, more emotional, kind of crying and so on, and reactive. Then you get drowsy as it goes up and a little bit lethargic. And as the level kind of continues to increase, you become stuporous or confused. And when it gets above 0.4, 0.5, 0.6, you get into respiratory depression. So I have seen through my career in the ICU, a gentleman, this is when I worked in a rural community, who came with a blood alcohol of 0.624, who was talking to me, right? And who could walk, right? His speech was slurred. He was making sense. He knew kind of where he was at and what was going on. So he had a really high tolerance for alcohol. Let's break it down a little bit. 160-pound male. So you say, okay, well, when am I going to be across that threshold for the average person to say I'm going to get a DUI or I'm above the legal limit? For the average 160-pound male, for the average standard drink, that's about 3 drinks. You're knocking on the door for getting that 0.8. 3 drinks for a woman will put you over that legal limit. And so you can see what 6 drinks does for both, right? And again, metabolizing. So how long is it going to take to get out of someone's system? 0 or kinetics, 1 drink per hour, okay? You have 6 drinks, get it all out, it's going to take about 6 hours. Someone comes in and you're seeing him in the ER, you're seeing him in your office or whatever. Most cases, you don't need to do much of anything. It's when if they have medical comorbidity or there are other problems, you may need to think about an admission to the hospital. Standard blood work, I'm not going to go through that. I think most people know that. The thing I do want to add is make sure you're checking for impaired liver function because of slower metabolic rate and a urine drug screen or some type of drug screen to see if there's other substances on board. That's pretty important. The Wernicke's encephalopathy, everybody learns about that back in med school and residency. The majority of cases are not recognized. The majority of cases turn into Korsakoff psychosis, which is an amnestic kind of syndrome. The classic triad that you see on the screen doesn't usually present that way. The most common presentation is a coma and somebody in the ICU from developing this. So you always want to use thiamine before you use glucose for a number of reasons. Partly because if you don't, some of the metabolic breakdown products are toxic, if you will, and will interfere with Krebs cycle, will interfere with mitochondrial function, and you get residual effects that are in the brain and in memory centers, and especially in the cerebellum. So we talk about memory bodies, but in hypothyroidism, especially within the cerebellum. So what happens when someone drinks, okay? And I've kind of gone through this. Opiates are released. Opiates downstream then stimulate the production of dopamine, okay, in various areas of the brain, and then you get a reinforcing effect. So that reinforcing effect is driven and associated with emotion, people, places, and things. So if you're hanging out with someone and using alcohol or cocaine, and you do it enough with that individual, and you're snorting cocaine or smoking crack or whatever enough, over time, what happens is without the cocaine even being there, that person that you're used to being with will trigger that pathway, it'll activate that pathway in the brain to say, I'm used to using with this person, I want to use, or this feels good, or I like this sort of thing. So the circuitry is activated, just like the sight of cocaine would activate that circuitry as well. Over time, what happens is GABA's increased. So when we drink, right, GABA is a relaxer, right? Gamma-aminobutyric acid relaxes us, slows the brain down, slows the nervous system down, slows the body down. But a compensatory mechanism over time is glutamate goes up. Remember, glutamate is excitatory, activating the nervous system, okay? So you can see here in the scale that when someone either cuts down drinking, that's been drinking quite a bit, or quits drinking, you have too much glutamate. That's what drives the withdrawal. So you get the autonomic systems, increased blood pressure, heart rate, sweating, nausea, vomiting, diarrhea, those sorts of things. But it's largely driven initially by the effects of having too much excitation in the central nervous system by glutamate. And that'll lead to some of the treatments we're going to talk about incidentally in a little bit. So how quick's this whole kind of withdrawal thing start? You know, within, depends on how much you're drinking, depends on how much you cut down or stop, but usually in the neighborhood of about 6 hours. And it peaks usually within a day or day and a half, and then usually resolves in about 3 days. That's the standard kind of withdrawal, right? For most people. Now, that's delayed a little bit as we get older. So if you get somebody, 65, 70, and so on, is drinking too much, that's, not only delayed, but it's prolonged as well. Treatment of choice usually is benzodiazepines, and to manage the treatment of withdrawal. How do you manage it? Well, you can use the old-fashioned way and load them if you want, meaning you just say, I'm going to give you, 10 milligrams of Valium 3 times a day, and we'll monitor and see how you do and adjust the dose. Or you can use a symptom-triggered approach, which is a CWAS scale. I don't have that in here, but CWAS scale rates a whole bunch of components that drives the decision-making around how much of a benzodiazepine you should use. Often we use a benzodiazepine like Ativan because it doesn't rely so much on the liver for metabolism, but longer acting are even better for someone who has no liver problems. So whether it's Librium or Valium, those are better options. And anticonvulsants sometimes are used as well. About delirium. Alcohol withdrawal delirium has a mortality rate of about 5 to 15%, depending on the individual. The more episodes you have, the higher the mortality rate. It's not only being disoriented and often having hallucinations, but marked autonomic instability that goes along with this. And it starts a little bit later. Starts 2 to 3 days into the withdrawal, and it lasts usually 7 to 10 days. Often these individuals need to be in the ICU and monitored very closely. Okay, I've covered this already. 14 grams in the average drink. I'm going through some definitions and building on another kind of platform we're going to talk about. So that's a 12-ounce beer, if you will, that has 5% alcohol. It's basically 5 ounces of wine that has 12% of the wine, or 80 proof, and an ounce and a half of a shot. So people say often, well, what's a fifth? A fifth is a fifth of a gallon. Okay, so in a fifth, that's 750 mils. There's 17 drinks. So the little fifth bottles that are of whiskey or various forms of liquor. People often wonder, well, what's that? That's considered a fifth of a gallon, okay, which contains 17 drinks and within it. How about within the average kind of bottle of wine. How many drinks are in there for a standard drink? 5. So it gives you an idea. People often kind of, well, what does this really mean? And what are these terms that we talk about? Now, what are the guidelines? What are the definitions in terms of guidelines? For heavy drinking for men is 4 or more drinks in a setting, okay, or more than 14 in a week. Women is 3 or more in a setting and more than 7 in a week. And what's a binge? For males, binge drinking within, and females, occur within, we're talking a 2-hour time period now, right? Of 5 or more drinks for males or 4 or more for women or females, you know, so 5 and 4 in 2 hours. So when we think about what is an alcohol use disorder, you can go to the old Diagnostic and Statistical Manual, and there's 11 criteria in there. And I want to simplify it, and I call it the 4 C's, right? The 4 C's, and the stronger these C's are, the more likely somebody has an alcohol problem or a substance problem, not just alcohol, but a substance use disorder. The first that happens in the natural progression and natural history of someone who has an alcohol or a substance use disorder, the first thing you usually see is loss of control, okay? Inability to manage how much they're drinking, inability to control or cut down. I'm only gonna have a couple today, and well, that turned into a 6-pack or turned into a, you know, half of a fifth or what have you. So loss of control is the first thing, okay? The next thing that typically happens with most individuals is, and it's not one of the C's, but I'm going to tell you the progression, I'll come back to it because it's somewhat related, is not only loss of control, but then there is this process where we go from kind of a conscious awareness to a subconscious process that takes place with anticipation. Anticipation is a huge part of substance use disorders. Anticipating what's going to happen when I drink and the effects of the substance I'm using and how that feels, and looking forward to that 5 o'clock or whatever. It's that excitement around anticipation that changes from a conscious to a habitual or automated or almost unconscious process. The second C is a compulsive drive or nature to use. So it's somewhat tied to that, if you will, anticipation, but that's compulsive drive or nature to use. The third is use of the substances despite consequences. Marriage problem, job problem, missing my kids' events, whatever it may be. Consequences as a result over time. And the fourth, which starts out of conscious awareness through this circuitry that's in our brain, are cravings. So cravings, once they reach conscious level, remember I was talking about seeing cocaine or being with someone and that circuitry being activated? That's that craving circuitry that we have. We all have it in our system that can be activated if we become someone who has a substance use disorder. And so that craving starts out of conscious awareness, reaches consciousness, and I want to do something to relieve these kinds of symptoms that I'm experiencing at the time, at the present moment. So if you think about someone who has a alcohol use problem, 70% of people never really have an issue that drink alcohol. And, you know, basically another 25% are, the 21% and the 5% are usually do okay. And now you get into that small percent of people that have that chronic relapsing condition, that severe dependence that turns into chronic dependence. Chronic dependence is not only that kind of relapsing condition, but it's often with high blood pressure. It's often with psychiatric illness or mental illness. It's often with liver impairment. It's often with pancreatitis, those sorts of things that result from alcohol use. So it's in that group that some of the treatments that are longer term or AA is most effective. Here's what happens during the natural course of that group that's more severe. You take in larger and longer amounts than intended. Your cravings intensify. You develop tolerance over time. And remember, tolerance is largely genetically influenced. So higher tolerances, drinking more or consuming more, and more problems as you spiral down into the kind of framework of someone who has an addiction or a substance use problem. Just pay attention to the blue here. Okay, that's really all I want you to see with this, and I'll get caught up. 43% from this study, and this is a pretty large study that was done, 43% of heavy drinkers do not meet criteria for an alcohol use disorder. So often we'll jump to that, oh, they have a problem, when in actuality they don't. I don't like these slides. So there we go. Okay, when does it start for most people? Alcohol use problems start for the majority of people between the ages of 18 and 25. The largest group is adolescents, 12 and 25. So you can see between 12 and 25, the majority of substance use disorders start. Between the ages of 18 and 20, 25% of them start. Those groups that are in that group, okay, that 18 to 20-year-old group that develops an alcohol use problem, okay, by the time they're 30, 70% of them no longer have a problem. By the time they're 30, 70% without treatment. So that gives you an idea of kind of where we've gone with some things. But substance use disorders and psychiatric illnesses, the majority of them start between the ages of 18 and 25, and you could even say down between 12 and 25, really. Not all substance use disorders start then, not all mental illness starts in, the majority do. So here you go, prevalence is peak right around just before the age of 21, or right in that study, but it's 18 to 20. First treatment is usually 10 years later, okay? So let's look at this slide here. 70% of individuals that have, and I said this a little bit ago in a different way, that have an alcohol problem have one episode in their life that lasts 3 years. That's what they have, and they don't have another episode, 70%. So we have this notion in our society that once you have an alcohol problem, you're doomed and gloomed, and you're going to have it the rest of your life, and terrible things are going to happen to you, and the family beats you up, and they make you feel bad, and so on. And the reality is not how it works for the majority of people. The average episode for someone who has for someone who has greater than one episode, they will go on to have 5 additional episodes, and each time the length of problems that they have gets a little bit shorter. So the biggest majority only have a short episode. Now look at this pie graph here, if you will. This is of individuals that have had an alcohol use disorder in any given year. And you'll see the darker color dependent, 25% still remain dependent. The rest of them either go to controlled drinking or they're not drinking at all. So what percent of people that have an alcohol problem can go to controlled drinking? Because we say, oh, you can't do that. About 10 to 20% can actually return to controlled drinking. Herein lies the challenge for that group, and it's a real conundrum, if you will. That group knows that if they push it, they're going to get into trouble. So they're spending a lot of time and energy and effort fighting not to drink too much versus not drinking at all. And so it's possible for some individuals, not that group on the far end that has that chronic kind of progressive condition. So what are the take-home points? There's a lot of heterogeneity within this. Most heavy drinkers don't have addiction, and most alcohol dependence is not chronic or reoccurrent. That's not what we're often taught, though, but that's what the studies bear out. What affects risk factors? And let's get into this a little bit here, okay? Individuals that are impulsive, extroverted, have lots of anxiety, social anxiety, risk takers, push the threshold, right? Those, especially young males that develop conduct disorder occurs before the age of 15. That's males that lie, cheat, steal, run away, beat people up, don't feel bad, that sort of thing, set fires, okay? In order to develop antisocial personality, you have to have conduct disorder to begin with. So conduct disorder and natural progression turns into antisocial personality. When you look at the group of individuals that have antisocial personality, heavily genetically loaded. Their fathers almost always have an alcohol problem. Their tolerance is really high. They have those things that I talked about that are genetically loaded. High tolerance, they don't have withdrawal. They get excited when they drink a lot. Those sorts of things. So they run into a lot of troubles with substance use problems if you have antisocial personality. It's also increased in individuals that have bipolar, schizophrenia, social phobia, and PTSD. This is just within the psychiatric realm. Now I want to go back to the top one here, ADHD. This was controversial until a lot of the studies came out, and there's an enormous amount of literature now around attention deficit hyperactivity disorder and the natural progression of it. And the preponderance of evidence suggests untreated ADHD, especially in the moderate to severe range of ADHD, results in much higher problems with substance use disorders. Not just that. Not only learning problems and limitations within school and a career if you have untreated ADHD, but much greater risk for motor vehicle accidents, much greater risk for sports injuries. And so there's a lot of things that go along with ADHD. And if you have a young man or woman who's in sports and involved with sports and they now get hurt and they have ADHD and they're separated from doing, if they love their sport or activity and they're separated from that, their chances of using a substance even goes higher. So ADHD is an important kind of thing to think about as well. You've heard me say this, overall substance use disorders, there's about a 50% kind of genetic loading, 50% environmental kind of loading. Higher genetic loading with those characteristics that I discussed. Males have a greater risk for kind of the disinhibited, impulsive sorts of behaviors that are genetically determined, whereas if you look at kind of the individuals with females, there's other characteristics. There's a lot of similarities between substance use with males and females, but the risk factors are a little bit different. Women with, especially that have anxiety and depression. That's basically what these slides have said. Ethnicity, whites are greater than African Americans to develop an alcohol use disorder. I mentioned about the metabolic machinery of alcohol dehydrogenase and that enzyme in some Asians. Native Americans have higher risk, and Latinos are about the same as kind of the general population. And so again, there is some cultural, ethnic modeling sorts of factors. Let's go into that a little bit. You see mom and dad drinking, or whoever you're around growing up as a kid, you're much more likely to assume that's the norm. Also, we know that kids that are around, that are in the adolescent time frame, that are around other kids that use, this is common sense, right, are more prone to using. And so that's also a variable. And you can see the geographical kind of predisposition for highest ranges of alcohol use. A lot of this comes from George Valiant's work and the longitudinal aging study, or if you're familiar with that. So let's change gears a little bit. I'm assuming the majority of you in here have a license, right? And if you get in trouble with your licensing board, okay, the majority of individuals that get in trouble with their licensing board that are in healthcare, about 80%, 80 to 85% are related to substance. And so there's, in the state of Nebraska, and I'm going kind of down a different path here, but I think this is important because it's a confusing point. We are one of 2 or 3 states that does not have what are called healthcare programs. So whether it's a nursing healthcare program or a physician healthcare program or what have you, we don't have anything designated. There are EAP programs. That's considerably different than what I'm talking about. Every 48 states have what are called, let's take physicians, have physician healthcare programs, okay? In the state of Nebraska, we do not. And in the legislation for the state of Nebraska, if you're reported to your licensing board and the case is open It becomes public knowledge. I know that because I was on the board, John's on the board now of medicine. It's true of the licensing boards in Nebraska. There's no protection. So healthcare programs provide that level of protection. The majority of cases that get reported to a licensing board do not get opened. But those that do, it becomes public knowledge in the state of Nebraska. That's a big deterrent to say, I'm going to, oh, I'm drinking too much and my name's Todd Stull and I'll tell you all about me, because now the board knows about it, the public knows about it, I can be scrutinized, humiliated, embarrassed, and that can create a whole nother set of problems. So it's a real kind of challenge when we have that issue kind of hanging above us in our state. We're working on developing healthcare programs across the spectrum, so there is that kind of protection, knowing that 80% of individuals that get reported to a board or the case is open is related to a substance use disorder. And the outcomes for healthcare providers are better than the general population. So I wanted to make you aware of that, and also to say that earlier interventions or doing something earlier is of benefit. So let's, it'd be like, I know this is going to sound kind of funny, but so typically I wouldn't wait as a psychiatrist to treat somebody who has depression until they attempt suicide. I typically wouldn't wait that long. I mean, I suppose it could happen, but you wouldn't typically do that, right? Well, I'm going to treat your hypertension after you have a stroke. We don't do that, I hope, right? And so we want people to think about, if they've got problems, the earlier they do something about it in healthcare or other areas, the population you treat, you can change the natural trajectory or the outcomes often by earlier interventions. We have to make it a kind of a normalized discussion. So what reduces risk? Going to church, having both parents at home, male figure at home, kind of the scaffolding, we stick together. This is the modeling, right? And the ability to say no. Parental involvement is a huge issue and often overlooked. Oh, I did it as a kid as a justification, so it's okay. Or I'm going to leave liquor in the cabinets and so on and be gone for the week and expect nothing to happen, and those sorts of things. And my kid would never do that, right? And maybe they wouldn't, but those are the kinds of mindsets that often can create problems. We have gotten a lot of attention lately around other risk factors, especially adverse childhood experiences. Adverse childhood experiences lead to chronicity for medical problems, whether it's cancer, metabolic diseases, or atherosclerotic coronary or heart disease or vascular disease, in addition to adverse experiences. When I say adverse, I'm talking about physical abuse, sexual abuse, neglect, those sorts of things. We know psychiatric illness goes up. We know substance problems go up and outcomes are worse. So it's a really important kind of thing. And here's the interesting thing. The new emerging literature for adverse childhood experiences, you're much more prone, for example, to develop depression as a kid, right? Antidepressants don't work for it. So you've got to think of other strategies to manage these individuals, as opposed to thinking, oh, I'm going to put them on a medication. Replacement behaviors, that's alternate reinforcers. I told you the 4 things for determining outcomes, that feeds into that. Okay, so we're moving down to the home stretch here a little bit. When you think about heavy drinking, okay, majority of people along this kind of arrow here don't have problems. It's only into the far right, as you're looking at the screen here, that you start to really kind of chase your tail. And so this is just another way of saying that. But the thing I really want to emphasize here on this, and I don't know if this works as right here, brief motivational kind of counseling. Let me elaborate on what I'm going to talk about. I believe that the majority of individuals that have a mental illness and a substance use disorder, either or both, can be managed and treated in primary care clinics. I strongly believe that. I believe it's a part of their healthcare. I think these conditions are so common and they affect other medical conditions, whether it's hypertension or management of diabetes or other, asthma or whatever the case may be. And it doesn't take as much energy or effort as what you think to do something. So it's asking a few questions up front. Let's digress a second. Patient comes into your office, you're a primary care provider. You have a scheduling process, you have a rooming process, who does what, and you kind of break it down. You've got somebody that's going to take vitals, maybe draw blood if needed, give shots and so on along the way. Everybody has kind of their role. Vital signs are common, right? Somebody comes in, I think everybody knows that. Our vital signs in this world are screens. They don't take long to do, they're short. Because if someone's blood pressure is 160 over 110, you're going to do something. If they're 200 over 150, you're putting them in the hospital probably, in a little bit panic mode, right? If they're 140 over 90, maybe depends on, there's more variables in. Somebody who fills out a screen in the substance world to identify substance problems or mental health problems, depending on that level and what comes from the screen, if they're honest, can determine kind of the next steps in terms of what to do. So when you treat someone that has a substance use disorder, you don't think of it as a one and done. If I have hypertension and I got the right weight and I'm exercising and I'm eating right and so on, and I still have hypertension, and you put me on medicine because I need it to reduce the risk of heart attack, strokes, kidney failure, and so on, you're not going to say, well, Todd, we're only going to give you this a year and then we're going to pull the medicine. You're going to treat me for however long that seems reasonable within that to treat me. It's the same when it comes to someone who has a mental illness or a substance problem. So it's not this big, long, prolonged session. It's hanging in there over time and asking the right questions. And we'll get into that a little bit. And most people, if you forget most of the things I've told you today, when someone gets in that chronic end of substance problems, there's one word I use to describe that. One word that will stick with you. So when you walk into that room to see the patient and you're irritated because you know their drug screen is positive for whatever, I want you to think of one word for that chronic group: loss, L-O-S-S. Because the further someone progresses down having a substance problem, the more they're losing. Family, friends, job, financial status, the sense of who they are. They're losing over and over. And that's like saying to someone, well, gee, how many of you, raise your hand, how many would like to wake up and have cancer? No one wants to wake up and have cancer. No one wants to develop a chronic substance problem where they're losing all these things. So it'll give you kind of a little bit of, because sometimes these patients can be very frustrating, right? And it will give you a little bit of a way to kind of ground yourself, check yourself at the door. And believe me, I need to do that frequently, just like anybody else, to say, wait a minute, what's this person going through? And they've lost their marriage, they've lost their job, their whatever. That's for the more severe group, right? So what treatment strategies should we use? There's a number of them listed here: contingency management, cognitive behavioral therapy, motivational interviewing, community reinforcement for families. That's where you get families together and help educate them, help them to understand kind of the nature of a substance problem. Because remember, just like the 10-year-old that develops type 1 diabetes, mental illness and substance problems are family problems. A 10-year-old can't manage their diabetes. They need the assistance of mom, dad, or whoever else is there to help them to learn to manage it and to be with them and not beat them up for having diabetes, not getting on them because they develop type 1 autoimmune diabetes, right? It's the same with substance problems. Substance problems and mental illness are family problems. And if the family is harsh, outcomes are not good. And so that family needs to be involved. However, take home point here, look at the top thing, brief motivational interviewing. Those questions that I'm going to show you here in a second are really key to changing kind of and helping that individual with the outcomes over time. When you look across the spectrum for AA, contingency management, cognitive behavioral therapy, things you see on here, outcomes aren't much different, right? All of them have an effect if the individual is committed to them and will buy into them, okay? I've already kind of gone through, let's be less confrontational, let's manage this over time as a chronic condition, as a health condition. Conceptualize substance as a health condition. It makes it a little bit easier, okay? So, most people that have a substance use problem don't need specialty treatment, including alcohol, right? There's no advantage to residential treatment. This is going to irritate a lot of people. When you look at the data, and I've done this 30 years now, when you look at the data for residential treatment, the data is not real great in terms of, oh, let's send them off to rehab, right? There are some people it clearly works for. The majority, they don't need it. Not only they don't need it, they don't want to go, and 93% of them don't go, right? And 70% of those get better on their own. And it's a lot of money. And incidentally, anybody have any idea how the 28 days was determined? The two guys, not Bill Wilson and Bob Smith, who found AA, but the Minnesota model. They decided we're going to do 28 days because we have 28 days of different lectures we're going to give. So it seems to make sense. There was nothing to, no data to support this is what we need, the treatment or length of time or what's being done. And so there's a lot of that within the substance world, that there are misconceptions and information that's not accurate. Okay, so if you look at, and this has 14.5 million in 2019, that number ranges around 15 million per year, okay? And that have a alcohol problem, right? Knowing that, as I said early on, there's three kind of substance use conditions where we have medications for: nicotine, opiates, and alcohol. And there are only a small percent that receive medications like mental illness. And I want to emphasize a point here, okay? When you treat someone who has a psychiatric illness or mental illness, let's say depression, it may lower the intensity of their symptoms. Medicines do not help you develop coping skills. Medicines don't give you the ability to learn how to have conversations or manage difficult situations. So there's that aspect of what's going on. So medicines in this case may change the reward circuitry that we've talked about a little bit, or may serve as an adversive agent. So disulfiram, Antabuse, been around a long period of time. This medicine can't be taken when you're drinking, it'll make you sick. So let's say I take Antabuse, 250 milligrams a day, right? And I drink on that. The majority of individuals, acetaldehyde is going to build up because remember that enzyme, acetaldehyde dehydrogenase that we talked briefly about earlier, gets blocked. So acetaldehyde builds up, what happens? Nausea, vomiting, diarrhea, dizziness, hot flashes. I feel absolutely terrible. And this reaction lasts 30 to 60 minutes in many people, and it's an aversive agent, prevents them from wanting to consume. Maybe not the most effective, right? And there are side effects with it. You can't use it with people that have liver failure or liver problems and so on. And but it's been around a long time. So Antabuse reaction or disulfiram is one option. Now, how about if we want to balance that glutamate GABA system? Acamprosate or Camprol, which is dosed 3 times a day, so that's somewhat inconvenient, tends to modulate the effects of glutamate. So it dials down the intensity of that glutamate system, so it's not as heavy and blocks it a little bit, so that there's not as much reward in the process when someone is taking it. The data for acamprosate is not overly robust. It does work in some individuals. Along the way, we figured out Topamax cuts down the number of heavy days of drinking. So that's also worth thinking about in some individuals that maybe have not responded to other medicines, and it maybe is in a relatively low dose. It may be like, 25 or 50 milligrams, it may be higher. But topiramate or Topamax may cut down heavy days of drinking. And I don't want to get too wrapped around the axle in some of this. I do want to emphasize a couple points here, though. We do have the most data from naltrexone. It's also called Revia, the long-acting form of it, injectable. It's called Vivitrol. It's a monthly injection. It's an opioid antagonist. There are other antagonists out there. So to reverse overdose on opiates is naloxone. Nalmefene is another opioid antagonist that can be used just like naltrexone. It's used more commonly in Europe for alcohol use disorder. This blocks those opioid receptors so that the opioid receptors can't go downstream and stimulate dopamine release. And if you don't stimulate dopamine release, you don't get the reward of drinking or the feedback that it feels good to drink because it's blocked. Naltrexone, oral naltrexone, then has lots of trials, lots of studies to show that it is effective. And the effect size is so for those of you that wonder, is about the same as the SSRI. So we're not talking about knocking someone's socks off with an effect size, but there is an effect size that does tend to help individuals. So it does a few things. It's kind of interesting. Besides cut down that reward circuitry, and it seems to be most effective in those with European lineage. It cuts down the reinforcing effect, but it also decreases the amount of alcohol that's consumed and the frequency of consumption over time. So you're on an antagonist here. If you need an agonist or you're going into surgery, you're going to need to think about how to manage that situation or override it, especially if you're on the long-acting Vivitrol monthly injection. Okay? Now, there was a guy that was from the US, David Sinclair. He is not the biologist from Austria that works at Boston who's doing a lot of stuff with aging and various aspects of aging. This is a different David Sinclair. I went over to Finland many years ago because they had the most robust kind of scientific lab to study alcohol over there. And he developed this method after a lot of his studies and working with a lot of patients to show that naltrexone does some interesting things in some individuals. It not only blocks the opioid release, which prevents the dopamine release, he already knew that, but it can be used in individuals to help in an extinction response for drinking, but more commonly, he found from his studies, and there's some people that do this in the US that are have had good success with it, that if you know someone who has a substance problem and it's not chronic, and they want to manage their condition through a harm reduction approach, we do harm reduction all the time, right? Think of harm reduction as managing blood sugars with whatever it means, medication, or harm reduction and treating hypertension, right? Harm reduction in this context is, I'm going to take some naltrexone before I go out tonight and drink. Because for those that it works in, they don't drink as much and they don't have problems. So it's a unique way of kind of approaching things. Not everybody agrees with that, but there is some real merit in kind of controlled drinking for that group. So kind of at the end here, we don't understand kind of the mechanisms that change drinking behavior. Most change either or does not occur with professional help or mutual help, and current programs really are not accessible to most people. Now, I told you I was going to come back to the two questions. They're in the next slide set, but I'm going to talk about them here. Do your screens, if you're willing to do them, for substance or psychiatric illness or mental illness. They don't have to be long screens. Don't be afraid to ask the questions about what you're using, and has it been a problem? And we'll get into this more when I do the second round, and then advise them on what to do. We know that just with physician involvement, short interventions, consistently through the studies, 25% of people can change kind of their use patterns to where they're no longer problematic. That's 1 in 4 people. That's a pretty good number, really, when you think about no one being involved. I want to go to one other thing here, and then we'll be done with this part when we take a break. So AA, and I'm not knocking AA, I just want you to be aware of this, because the notion is we're going to send you to AA. Okay, and I told you earlier, AA is the most effective for that chronic group. AA is anonymous, right? Alcoholics Anonymous. So it's hard to get their data, but there's some people that have been able to get the data and study them over time. And if you look at whether it's Dobbs' work or McClellan's work or what have you, they came up with, they independently replicated this, and I've found this really fascinating. At 90 days, 81% of people have dropped out of AA on average, about 80%. So you got 19 or 20% left. Of that 19 or 20%, 36% are abstinent 10 years later. Of the total 100 that went, that's 6%. That's a small size effect. 6% versus 25% versus what you can do just by a simple ask and follow up and so on. AA is useful for people that believe in it and commit to it, which is a small number. And it works for those that have more severe or chronic conditions. And so just keep that in mind if you really want to make kind of an impact on someone in terms of kind of their substance use and so on. I'm not saying they shouldn't go to AA. That's not my point. I'm just saying the data that we have right now is not very robust to say that they're overly effective, except for that group that sticks with it and commits to it. And you'll find that that group that sticks with it and commits to it, they're the sponsors, they're the leaders, they're the, they're taking all the kind of those roles, and you hear about that, but you don't hear about the 81% that quit going. All right, so let's take John, how long do you want to take a break for here?
I'm John Massey, and I'm happy to be here. I'm happy that you guys are all here. We know that people are here because of the change in the DEA and the rules and to get your license and the 8 hours required. We've been spending a lot of time with various projects and with various efforts to make this meaningful rather than just something that has to be accomplished, fill the gaps, information gaps, but also provide relevance. So hopefully my discussion over the next hour is going to be a practical discussion about some of these issues, and you're going to get a couple of, I don't know why the microphone kind of crash out, but we know this graph, right? This graph is kind of thrown in the news all the time, and it's a fascinating story, and you can watch it on Netflix now and several different documentaries, but we want to remind ourselves that this all kind of began 2 decades ago with some really bad science. Those of you who don't know, in 1999, a couple of physicians just wrote a letter to the editor that was sent into a journal that said, we've been managing post-operative patients with opioids to help get them out of rehab a little quicker, and nobody developed addiction. And that paper was eventually the basis of starting opioids as a prescribed non-cancer pain, non-end-of-life pain, began in 1999. It's been positively quoted 13,000 times in the literature. Almost nobody ever looked at it and said, was this a real study or not? And so that started a prescribing pattern. We pain is the 5th vital sign. You all know this, and that began this cascade. And And as clinicians, took us about 5 or 8 years to figure out that maybe the Sackler family wasn't doing us the best justice. And so we started to look at that in the early 2007, 8, 9, 10 region. And as you all know, we changed our prescribing patterns very substantially, curved it downward. We started worrying about who to prescribe for, and we de-prescribed for a number of people. And then right after that, heroin shot up. So we had lit that fuse as clinicians, and now people were getting these medications illicitly. And so you got the second wave that began. And then the fentanyl derivatives, first from China, now through South America, Central America. Now we're having this huge wave of overdose deaths, right? 20% increase from 2021 to 2023. Might be related to the pandemic, but probably worsening of the disease, worsening of the analogs that are coming through. But the real issue about this is we're getting funding. We're here. We've got several projects. We're working on this, but we're not the prescribers as much as we used to be, right? We're less the prescribers, but we are not less of the problem. And so we're here. We're trying to make the point that all of us are in this, and we can make this. And it doesn't really require us to say, okay, I'm now going to be providing office-based opioid use disorder treatment in order to be part of the solution. If you understand the tenets, what Todd was talking about in the last hour, what I'll be talking with, you'll realize that our thesis statement here is that we can all do this. And we're seeing this problem every day in our clinic. We're seeing it at earlier stages. And if we intervene in an important way, we can get a better outcome. In 2007, when we first started looking at this, is one of our original studies that looked at it. We found out that prescription of opioid abuse was costing the U.S. economy $57 billion a year. That number is now triple. The problem is now triple. Workplace costs are now $100 billion a year in 2023 numbers. Direct healthcare costs are $75 billion, and that's despite a lot of investment in research and work to try to make this problem better. Fundamentally, we might be missing some of the ways that we can make a change, and we'll talk about a little bit that today. But it led to the regulatory response, and that's why we're all here. The regulatory response, we all respond to this in a way that's predictable. When the CDC guidelines first came out in 2017, how many of you can remember your response to, okay, there's CDC guidelines for opioid prescribing? Can most of you remember how you became aware of that? And then the next question is, your first blush on this, did you have a positive impression of this? Or were you kind of skeptical, frustrated? Can anyone remember who here thought, okay, I don't know about this. I've had a lot of interactions over the years with clinicians who assume I'm a pain provider. They come to me saying, oh, can you believe what the CDC did? They're looking at us and all this stuff. And it's really very interesting. And what the work they did was very well grounded in science. And there were some problems, but it wasn't really a problem with the guidelines as much as what people were doing with the guidelines. So they were revised in 2022. And I would make the argument they were revised to better help us as clinicians, protect us from people who had predatory desires on misapplication of those guidelines. And we'll talk about that a little bit. Also, in 2000, we started providing office-based treatment for opioid use disorder with buprenorphine. And Todd and I have been involved in that training for some time, trying to get people to get their data waiver. But as the problem moved forward, the regulatory response, as you know, that went away. And as part of the legislation that got rid of the need for the buprenorphine or the data waiver, this 8 hours of training was required for all clinicians to get their prescribing, and that's why we're here. But there's also state responses as well too. So the state, remember, all of our licenses, all of our work, it's a combined federal and state project, right? Our state licenses are responsible for that. There are state guidelines. In Nebraska, there's the 3.5 hours you have to have in pain training every cycle. And the PDMP and access and all of that, of course, is moving forward. PDMP access is interesting. It's now a federal requirement, right? To get dollars from Medicare, you have to be using the PDMP as a clinician. Also, the state requires that as well to a lesser degree, but I'm involved in the Board of Medicine and worked with the Federation of State Medical Boards. And one of the things Nebraska's been very good about is encouraging us to use this. One of the things I'm aware of in the state of Ohio, if you are caught prescribing a opioid for a patient on an outpatient basis and you've been warned one time without looking at the PDMP, it's a $30,000 fine on the second offense. So you can see that different states with different ideas have taken different approaches, carrot and stick and so forth. But the point on this is that it's not that hard to do this correctly. You just have to be you have to be aware of where to go for the information. You have to be kind of incorporating this in a systematic fashion. I'm particularly happy about the CDC guideline revision in 2022. Does anybody the reason that this was so helpful to us as clinicians is that in 2022, the revision that's most important is that the CDC came out and said, do not de-prescribe for patients who are getting medications in a fashion that might be high risk. It is inappropriate to force somebody to wean down to the MME categorization that we think of as low risk. And it is inappropriate at any time to say, we're going to do this because, the government says I have to. And, it's also important that we understand that the insurance companies, many insurance companies, you'll get letters saying, we're not going to let you prescribe above 50 MME. And so as clinicians, we've said, well, I can't do this because it's outside of the regulations. I'm not allowed to write for more than this. Many healthcare systems do this, right? If you're a clinician, you can't prescribe more than so many MME for a patient. And that is specifically not desirable with respect to these guidelines. These guidelines say you should not do that, and you can't de-prescribe individuals against their will because of the risk of morbidity and mortality associated with forcing de-prescribing. All right, and it's death, it's suicide, and it's overdose that occurs when you de-prescribe because people go outside of the environment. So that's I think a very important understanding that we need to make, and that begs the question: then what are we going to do? How do we manage this, and what are our processes for doing that? The CDC guidelines are great because there was a background reason for it. They were appreciative. They were careful to say, who are we going to speak to? We know we have multiple stakeholders. We're talking to healthcare systems. We're talking to government agencies. We're talking to healthcare providers. We're talking to patient advocacy groups. And we're talking, we need data behind what we do. And we need a systematic review of the evidence, grading of the evidence, and understanding how good the evidence is and and then they brought people involved, the stakeholders involved, and they gave us a chance to comment on that. And only afterwards, with peer review, did they move and come up with recommendations. And those recommendations, therefore, are very solid, practical, and useful with respect to how we can move forward. But really what they're fundamentally about is, when is it a good time to initiate opioids and when is it not? When you're using opioids under the various different circumstances in which you do so, what's the safest way to do that? And how do we reduce risk by how we prescribe with respect to dosages, delivery systems, REMS, and what have you? What's the duration of the opioids? How long should we be prescribing? And then how do we assess harm and risk potential when we're using that? That's a big subject all by itself. And so it's kind of beyond this hour-long conversation to get into that, but I'm going to spend some time talking about where we can get you all that information most successfully. And I want you to know in advance that part of the MAID Act, that's what we're here. This is what you need to have to reapply for your DEA license. Really, the 8-hour training must be done one time in your life. It's really about the urgency of the nation's overdose crisis. They are specifically recruiting all of us as providers. Most of us who are older hadn't had a chance to get this kind of information in our training. It's a gap, it's an information gap, but they're really working very hard to make sure that all of us, it takes that village, and we're that village. And so in the training that we've already done, and it's all available, it's available to all you all, the MATE training through the Department of Health and Human Services and the NMA. We've had recordings of the various subjects here, and I'm specifically not going to try to make this talk a recap of all that. I'm going to try to talk about some of this, but really those are available, and those are all of those in combination. Any combination will satisfy the MATE Act requirement. So you're getting your credit for 4 hours here. Two more of those courses, you've equaled your 8 hours, and then what you can talk about. We talked about intersection of mental health, pain, and substance use disorders. One of the things we've had a really big emphasis on is destigmatization. Stigma is the problem here. It's the reason we don't have this knowledge in our knowledge bank to begin with, right? The stigma of the difficulty of treating these kinds of patients, the challenge in recognizing when these patients need to be identified, and then the stigma of providing database care rather than the kind of care that we provided in the past. So those kinds of strategies, comorbid conditions, treatment, and then how to talk about comorbid diseases. More training offers. Right now, this is an ongoing project, and I'm kind of here to try to make a pitch for this Project ECHO, which is an extension in community health outcomes. ECHO training is a type of training that's been around for a number of years, and it began when first hepatitis C training came out in New Mexico. All the people with hepatitis C were not co-located with the hepatologists. So they had to kind of find a way to get the people in the local area trained up. So ECHO training is specifically a training that we provide, and it's ongoing, free for anyone. CMEs comes at an hour at a chunk. And what we're doing with ECHO training is we're providing a hub team and anyone who wants to join on. And then we have a little bit of a didactic about these kinds of subjects like we're talking about today. And then associated with that, we have case presentations. It's sort of meant to be a little bit like a mini grand rounds while you're sitting on your computer, and anybody can bring a case and say, I've got this challenging case, I don't know what to do, or I'm stuck on a problem, I've got something going on. And then there's various members on the hub team that can ask questions. There's other participants can ask questions. It's very low intensity. It's just kind of a practical way to move forward with best care, and it's almost like a curbside consult that's associated with CME learning and helping. And the point of this is to get the knowledge and in care into the hands of people who are on the ground providing that. So this is something that's going on. One of those that's coming up in the next week. We'll be providing this throughout the year. Anybody can register who wants to, and we've had really great participation, and we'll be doing this in cycles. And we're about done with this last cycle, but the one Todd and I are going to be talking about next week, I believe, is transition patients via microdosing. I'm going to talk about that a little bit. It's one of our emerging real opportunities to provide care for people. And so towards this end, what I'm going to do today, I'm going to just kind of talk a little bit about how we think about pain in our world, pain and potential comorbid issues, substance use, opioid prescribing challenges, based on all of those processes that we've talked about. And then I'm going to try to put you with some cases. Instead of just going through a long didactic, I'm going to try to say, all right, these are kinds of practical things that I believe many of you would see in a day. And if you use the right ideas, you can manage these patients much more successfully. So I'm just gonna quickly show you some cases, and then I'm going to talk about a little didactic, and then I want to go back to the cases, and I want to see if we can generate some discussion about what we can do with these. And I just took these cases off of my schedule one day. So we've got a 37-year-old female, chronic pancreatitis, migraine headaches, question about endometriosis, scheduled for laparoscopy. She's had a past history of problems with that's what led to the pancreatitis. She's been abstinent of alcohol, but she does use THC. She lives in a part of the state that's, readily accessible to what, is described as medicinal cannabis. So she takes that for her abdominal pain, and she's also on typical agents for migraines with the addition of butalbital for her headaches. And she's taken hydrocodone 3 times a day for her abdominal pain, contemplating surgery. Think about that first as I'm going to go by this. We're going to go to patient number 2 here. This one's a 64-year-old male. He's had a couple of fusion surgeries in the past with a surgeon who sees what he thinks is junctional failure. They're thinking about extending the fusion on this individual, but he's smoking. So the surgeon says, I'm not going to do anything for you right now because we gotta have you stop your smoking so that I can fuse your next level and move forward. He doesn't work. He's disabled because of a back condition. He worked in a fairly heavy industry before. He's on 60 milligrams a day of MS-Contin and another 15 of hydrocodone, gets tizanidine, gabapentin, and Ambien at night for sleep. Comes into your office saying, I can't have surgery. I have back pain. I'm on these medications. What do I do? Okay. Case number 3, 73-year-old individuals with lumbar spinal stenosis, neurogenic claudication, hurts when I stand, hurts when I walk, it's okay when I sit down, except I also have burning pain in my feet, peripheral neuropathy from diabetes, has a history of restless leg syndrome, obstructive sleep apnea, very low activity tolerance. You can't really measure it because of the stenosis. She gets Ativan a milligram TID for a number of years. She's on tramadol 100 milligrams TID because I don't like those heavy opioids. I'm scared of that. Flexeril at night to help sleep as well. So the question here is, how do we manage this patient and stay within CDC guidelines? What are the risks of what are the choices that we might be making? Okay. So now, before we get into thinking about that too much, I'm going to, oh yeah, one more case. I'm sorry. This one, I added this one morning because this was my clinic and I'm trying to make it an echo presentation. So I'm like, all right, let's bring it to the group and see what they think. But I got a 39-year-old male with very severe diabetes, dialysis, end-stage renal disease, polyneuropathy, cutis calciphylaxis. Those who don't know that, that's calcification within the blood vessels leading to ischemic, leading to worsening of neuropathy. It's got an open ulcer in the cap that's not been healing for a number of years. On up to 90 milligrams a day of OxyContin with an additional 15 milligrams of breakthrough, a little bit of gabapentin, had been on Duragesic in the past in another state, does use THC, which is not very clear whether it's for recreational, but probably attempting analgesic control with this. Every other day dialysis comes in. What do I do, doc? So what's the problem with this? And here's where I think we need to understand a little bit more about the idea of pain and how to treat pain. We have a very Cartesian model of pain in the US, and some of us were talking about this earlier. Rene Descartes was the first individual, I think, therefore I am. He's the guy, Cartesian coordinates. He's the guy who first postulated that there was something, I don't think he even called it a nerve, but there's something that detected a tissue problem and it went to the brain where pain was experienced. So he was the first person to say there's a correlation between an injury and the corresponding response. And we bring that, 3.5 centuries later, we bring that to our clinic every day, right? Somebody comes in and they say, I hurt. We very diligently look and see what's the matter with the tissue at the structure that it's there. And we see if that's something that we can fix or not. And if it isn't, we think, okay, well, I can't fix that, so it's going to hurt. Or conversely, I did fix that and it shouldn't hurt, right? We get stuck in Cartesian models of chronic pain. And that's a very problematic condition because that's not the way the body works. In other words, whoever created us didn't make us like a bunch of wiring in a building where there's a switch, a wire, and a signal on a light that says pain. We're very intricate computer networks. So chronic pain, the real way we want you to think about chronic pain is the concept over here on the right side. And we used to call this central sensitization. Terminology we're using more commonly now is no. What that tells us is that the central nervous system is a learning structure. It's very involved, and it gets very efficient at sending a signal that it believes it needs to send for one reason or another. All right, we're familiar with concepts of phantom pain. We're familiar with the idea that there's referred pain from one structure to another, but what we don't really understand is the degree to which pathways are continually remodeling. Neuroplasticity isn't beneficial or detrimental, it's just a thing. So the nerves that are constantly doing something are getting better at doing that. And as they do that, you get this augmentation of a signal. And the augmentation of a signal is not just an incoming signal, it's a relative balance between inhibition and excitation, upregulation and downregulation at various points. And if it's a little more up than down, then you get a positive increase, and if it goes the other way, you get inhibition. And what we understand and what we really should be putting in our minds when we're seeing these patients is the degree to which central nervous system pathology is the problem, okay? And the other part about that that's very interesting, you see here we've got the dorsal horn, the dorsal root ganglion, right? A signal comes in, wherever it comes in through the posterior aspect of the spinal cord. It makes a synapse at the dorsal root ganglion. That DRG is the first place where you can get upregulation. There's a lot, complex regional pain syndrome starts out here. A lot of phantom pain starts out here. You get this feedback loop in the DRG that leads to an amplification of the incoming signal to the dorsal horn. So that's the first place where they happen. And then what happens is in the dorsal horn of the spinal cord, you get this amplification of the signal and you get recruitment of new neurons. There's a whole bunch of spare part neurons in the backside of the spinal cord that are just sitting there. And those signals, those nerves start to pick up signals as that frequency and intensity of the signal comes in, and they get busy and they make new neural pathways, new synapses are created. Interesting about that is we've learned for some time that when you have acute pain, those signals tend to stop here on the dorsal part of in the substantia gelatinosa, where all the mu receptors are in the spinal cord. And over time, as this signal comes through, these signals barrel on through and they go into deeper structures, more midline structures of the dorsal horn. So what do those neurons do? They drive right through the place where opioids can work. Fascinating, right? They just bypass that. So I'd ask you to think about that the next time when you're thinking about a patient who maybe had some relief with some hydrocodone for a while, now they're not. Don't think about the liver and don't think so much about the cytochrome P450 pathways and metabolism. Well, what's more, think about the fact that the brain is just sidestepping, blocking that signal. And that's one of the reasons that we understand this problem. But then the signal comes up through this dual pathways, the spinal thalamic tract and the spinal mesencephalic tract. Basically, those second order neurons coming up into the brain, they go right to the midbrain structure. They go through the midbrain, the periaqueductal gray area, for those of you who remember. That's where respiratory drive is affected by opioids. And then they go into the limbic system. And they tumble around in the limbic system, and all those interactions with dopamine and the other things that we were talking about earlier, that's where they start to occur. So before we're even aware of pain, it's been either upregulated or downregulated based on the pre-existing environment of the limbic system. Okay? So limbic system overactivity, what does that look like? Mood disorders, anxiety disorders, things like that, causes a change in that incoming signal. It's an amplification of that process, irrespective of anything that's going on at the nociceptive source. Only then does it go out to the somatosensory cortex, prefrontal cortex. Only then are we consciously aware of the signal saying, ouch. And now, in normal individuals or abnormal individuals, you get varying levels of descending inhibition, all right? Descending inhibition, those tracts are kind of commonly called the resiliency tracts. And that's where things like duloxetine and those kinds of medications begin to work. What do we know about the descending inhibition is that it is very often altered in individuals who have had trauma of one kind or another. I'm talking about adverse childhood events, people who have lack of resilience in other ways. They've had a change in the way their brain forms. So the kind of person who has a difficult time with resiliency has a difficult time with the pathways that cause inhibition. It's not causing their pain, but it makes it difficult for the system to attenuate itself appropriately. All right, we have to be very careful when we're talking about this and thinking about this, because this information is really easy to miscommunicate with patients, and we'll talk about that a little bit. But these are the things that are going on in chronic pain, and so when you're understanding these concepts, it's very easy to see how a simple molecule like an opioid can become problematic. And if we're trying to get it to do something that it's not able to do, then we're going to be causing problems. So what we really need to do is a couple of different things. Obviously, we're here to destigmatize the concept of use disorders, especially for me, opioid use disorders. But I also really want to kind of liberate ourselves from a simplistic understanding of what's causing this complaint. And we were having a discussion earlier about doing things. I spend a lot of my day doing things for somebody who has a pain complaint, and I'm trying to change the environment. I'm changing the nociceptor. I'm removing that source. But if I'm doing that in the wrong individual, I'm not going to be making any progress, because that's not the problem. I'm not really fundamentally changing the problem. So what's really interesting about this, and persistent pain causes all these different things that are different than nociception: sleep problems, functional disability, stresses. It changes your cognition, right? You can't concentrate because you can't get away from the symptom. So people have all these other problems that develop as sequela of chronic pain. Looky here, opioid use disorders, other use disorders have the same set of circumstances. And what's going on is there's a continuum here, and there's a lot of people who have kind of postulated the idea that chronic pain and abuse physiology is a continuum rather than a distinct set of disturbances, right? It's very difficult with opioid use disorder in particular, because there's the abstinence syndrome that everybody gets, whether they have a use disorder or not. But it's also really hard to understand, because the very same structures that are involved in the development of use disorders are the structures that are involved in the transmission of the chronic pain and the augmentation of chronic pain. So, thesis statement number 2, it's really never possible to successfully treat chronic pain unless you're also thinking about to what degree you're seeing use disorder physiology and/or mood and affect changes occur, because they're not separable. They're different parts of the same problem. And that is in no way meant to impugn somebody. It means that we have to be careful in how we co-manage these kinds of patients. What are the implications in chronic pain? It's really interesting. We understand that dopamine dysregulation is very likely, people with dopamine dysregulation are very likely to develop chronic pain because they can't attenuate that signal. So what happens is 5% of chronic non-cancer pain patients get 70% of the MMEs prescribed in the US, all right? And there's no other disease state that's been identified where exactly the wrong people for a disease get the medication, right? To me, it's as if we were prescribing sugar for diabetics because we're tired of seeing reactions, right? It's exactly the wrong thing to do. And there's a lot of reasons for that, but fundamentally, we start that early on. Who gets prescribed? People who have more diagnoses and people who have comorbid mental health and substance use disorders. That's just a restatement. How does this show up? This study basically tells us that low back pain and substance use disorder patients, elderly patients who have prescription opioid abuse, almost always have a diagnosis of low back pain. A very strong correlation, okay? So we may not be prescribing anymore, but we might have lit that fuse, right? And that's very strong. And the other one that's very interesting is comorbid mood and anxiety disorders in patients who are being prescribed opioids. And what you see with this is that there's an increase in depressive symptoms and opioid, but it's particularly increased with higher doses and prolonged use. And as a matter of fact, it isn't associated in short-term use. So what we're seeing is not necessarily the effect of the medication, but what we're seeing is that the wrong individuals are being prescribed because we don't understand kind of the boundaries and the efficacy or the lack of efficacy in what we're doing. Chronic pain population is obviously much bigger. We're here because people are dying from fentanyl, right? 110,000 people, despite the fact that we're doing everything. We're not all prescribing high doses of MME. We're not doing that anymore, but this is going on. But what does happen is for every one death in the emergency department, there's 850, 825 opioid misusers in the environment in the US, a very high number. And a lot of those individuals are being prescribed. So what we're really trying to do is say, okay, in response to all the money that the Sackler family is coughing up and every other organization, because they've done some really bad things with marketing and kind of, nefarious things with how they got people interested in this molecule. In exchange for that, we're not just going to knock down deaths. We're not just going to make sure everyone has Narcan in their backpack, which is important and part of what we've done with our project. But what we're going to try to do is identify those people earlier, because that's where we can make a difference. So if we don't step into that problem in the first place, we're going to do a better job. So what shows us the risk factors for development of opioid use disorder? Anybody who has other substance use disorders, which is part of why we're talking about these other subjects today. Family history of that, history of legal problems, conduct disorders, as Todd was talking about earlier, and of course, mood, mental illness. And I think PTSD we talk about a lot, but let's just talk about trauma, right? Pre-adolescent trauma, adverse childhood events, individuals who don't have those inhibitory pathways set up are at high risk of developing problems. And here's where we really have to change our thinking also. What we think of is, okay, how can I keep my patient comfortable and keep them safe, right? They may be developing some problematic use patterns. This might be outside of the CDC guidelines, but I care for my patient, or I believe my patient when they tell me they hurt. I hear that all the time. Those kinds of comments are nonsensical, because if you think about this problem as a very delicate dance between use disorders and chronic pain physiology, you understand that the opposite is really true. That if you make one better, you make both better. So in exchange for the idea that I can either manage your pain, or I can keep you safe, or I can keep prescribing you opioids, or I can keep you safe from developing a use disorder, we should say successful treatment in chronic pain is only possible once you address opioid misuse. Okay, that used to be a matter of deprescribing, which we don't want to do. We have tricks for that, much easier than we think. Again, that's why you guys have been coerced by the DEA to be here today. Dysregulated dopamine does one of the things that we know. One of the things that we know about the body is that it's very sensitive to the rate of rise or the rate of fall of dopamine, right? And so one of the problems with opioids, Todd was talking about this earlier, is kind of a side effect of getting into the mu receptor is when that mu receptor lights up, there's a side increase in dopamine that goes off as well. And then when that steps away, that dopamine falls. And the body is not sensitive to the absolute volume of dopamine in the CSF as much as it's sensitive to the rate of rise or the rate of decrease. So in particular, some of these less potent opioids that are administered more frequently, because we can stay under the MME number, can become problematic because the up, down constantly changes our dopamine activity. I'm not going to get to this yet. We're going to talk about these cases. So what are the problems that develop with this patient, right? We've got a patient with chronic pancreatitis. Do we know why? Do we know something about the alcohol use, right? We do know that there's abstinence of alcohol for 4 years, but there's ongoing use of cannabis. What does that reflect, right? It might reflect the marketing that goes on around cannabis, that it's, never going to kill anybody and it's much safer than everything else. And don't worry about it. It's really good for chronic pain and anxiety and PTSD. It's not really true. We don't have that data. We don't have data that says that. It might be somebody who's developing a change in their misuse from one substance to another, right? What else we know about this patient is that they're being prescribed butalbital, which is a sedative, right? A sedative for hypnotic. That is definitely not good care for migraine type headaches. It's kind of evidence of legacy thinking, probably a patient who is very well connected to their medication, very insistent on that as being, it represents a potential problem, right? It doesn't give us enough information. But then what we see here is an individual also with another chronic pain complaint. Endometriosis is one of those that it's very difficult to sort of say this much endometriosis equals this much visceral pain, right? So we've got multiple diagnoses, difficult to find the nociceptive source, individual who's got prescribed opioids along with sedative hypnotics. That raises the risk of overdose death by 500%, or misuse of medication by a higher number as well. So what you're seeing here is an individual who, despite the fact that they're really well managed from the standpoint of fitting under that 50 MME suggestion by the CDC, they're developing problematic patterns. What else do we see? We see a 37-year-old female, right? And chronic pancreatitis with a visceral neurogenic pain. We understand that to be particularly opioid non-responsive. So in essence, something else has to be done for this individual. And what's going to happen in this case, in the healthcare system in the US, we're going to do that laparoscopy and we're going to maybe laser off some of the endometriosis and maybe we'll get it all and maybe we won't. But we can pretty much be sure that this patient's going to have persistent pain afterwards. And now they've got postoperative pain. And I was already on 22.5 milligrams of hydrocodone a day. Now what are we going to do? So you see, we're starting to tumble down into a problematic area because we're maybe misapplying information about what medication could reasonably do for that patient. Does anyone, okay, so if we were doing an echo conversation right now, I'd present this patient and I'd say, all right, who has questions about how we're managing this patient? And anybody can say, well, you know, X, Y, Z, and can ask a question and sort of get information. And then the hub team would do the same, and then we'd start brainstorming answers for this. That's the process of the echo. I know you guys aren't going to do that in this environment. How about my 64-year-old male? Had fusion surgeries already, maybe 3, I don't know, 1 might have been a decompression, but now I've got junctional breakdown at the L2-3 level, so back pain, persistent back pain, we need to fuse that, but they're not going to do that ostensibly because it's not going to heal. You're going to get failed fusion with the nicotine effect on the blood vessels. Individuals not working, they're on 60 milligrams a day of morphine and additional 15 of hydrocodone. So they're just above the CDC guidelines. They're also on a muscle relaxant and they're also on Ambien, right? So that's the kind of the holy trinity: muscle relaxants, opioids, and benzodiazepines or Z drugs. That is preferred by individuals who are developing use disorder, right? And it's also a problem because these are the individuals who end up with respiratory suppression that's synergistically affected because of the combination of the effects of those drugs. So I've got an individual who's not going to get better because he's essentially got a nociceptive source, but he's outside of guidelines. What am I going to do to manage this patient? How do we move forward with that patient in a way that's consistent with best care and probably importantly, guidelines? What's the trick with that? Anybody want to ask a question or volunteer an answer? I'm not assuming they were, but I'd love it if somebody, yeah. Absolutely, great question. So what's the patient's goals? Expectation management, trying to see where the patient is reasonable, right? We're not going to get this patient pain-free, but this patient's dysfunctional. And great question, fantastic, perfect. We're looking at functionality. We understand functionality to be more closely associated with success than pain relief. Perfect question. Anyone else want to? Not Friday afternoon, somebody can ask a question. Sorry. We'll be talking about that, right? Benzodiazepines are super difficult. So what you're saying is, I'm going to try to de-prescribe which one do I start with, right? Very challenging, very difficult. That's one of the hours of this afternoon, but I love that you identified right now the Z drug, the benzo is particularly problematic. Yep. How do you do that is challenging. So maybe we won't do that first. Giving you a little bit of hint about this. All right. Anyone else want to ask a question or, oh, sorry. Well, I'm seeing him today, so I have 2 weeks, right? Because that's when the patient's going to report back to the primary care about whether I did a good job or not. But perfect question. Yeah. So yeah, perfect. What are your, again, how quickly do you think we can get this better? Great question. Yeah, ma'am. Sure. Yes. What are the drug-drug interactions related to chronicity? Chronicity is related to, how long these maladaptive neurologic changes have been around. Great question. Great question. Okay. Let's go to the third one, and then I'm going to start talking about some answers and see if I can entice you guys into expanding your armamentarium, if you will. So now we've got this is a little old lady, or I don't remember, it might be a male, I'm sorry, but neurogenic claudication. So, I'm doing okay most of the time, except if I want to do anything, right? Sitting around, I'm relatively comfortable, but I do have some burning pain at night that's bothering my sleep, and I can only tolerate so much medication. But since I can't sleep and since I get that burning pain, and so I've been on Ativan for a while, and but I'm not on high dose opioids. I'm just on tramadol, right? I'm okay on 600 milligrams or 300 milligrams a day of tramadol rather, and cyclobenzaprine at night. So what's the problem? This patient comes to me and they want me to try to fix the spinal stenosis, and now I have to think of, okay, how much do we need to change this? Does anyone want to ask me questions about, what you want to know before we kind of make some changes? Yeah. All right. I'm going to go, I'm sorry, my slides are out of order, but here's a little bit of a trick, okay? What if I told you that there's a study in the literature where they take a whole bunch of patients and they randomly divide them between their legacy high dose opioids, and by high dose I mean 300 to 500 MME of opioids of all different kinds, and they take half of the patients and they continue those opioids and they do everything that a pain doctor like me can do. This has happened through the VA. They do all this stuff, and then they take the other half of these patients and they randomly switch them over to buprenorphine. These people come into this, study, randomly pulled into it, and they're describing pain. It's measured in various ways, but suffice it to say that their VAS was somewhere between 7.5 and 8.5 on entry into the exam or into the study. And then at the end of 6 months and 12 months, they reassessed it. And lo and behold, the people who continued to be prescribed at very high doses outside of regulations or recommendations came back with all these surgical, cognitive behavioral therapy, physical therapy, injection therapy. At the end of the day, they were down to 6.5 to 8. So maybe a 1-point change in VAS. On the other side of the study were individuals who were immediately switched into buprenorphine. To be included in this study, you do not have a use disorder. You are just being prescribed, taking your medications as prescribed. You are just hurting. At the end of 6 months, their VAS was 2.5 to 3, right? So let's go back to our first patient with the fusion surgery and needing reoperation. If I could tell that patient, look, I can't make you all better, but I can take you from an 8 to a 3, you think they would take that? Yeah. Right? What's the risk of overdose respiratory depression with buprenorphine? Almost none. Almost not possible, even with some of those other medications. There's another study that said we took individuals with opioids and they were doing fine, but they were high risk. We didn't like it. We switched them into buprenorphine. I didn't do this. We switched them into buprenorphine, and then at the end of it, we judged how they were feeling. and some of them had a less significant drop in their VAS, but 97% of those patients said they preferred how they felt on buprenorphine compared to their legacy opioids. Okay? What does that even mean? What is going on with buprenorphine that's different? And we talk about use disorders, and I know from experience, we've been doing this for years, I can only convince some people to want to say, I'm going to treat opioid use disorder. But how many of you would like to sleep better at night, knowing that you can sneak buprenorphine into patients very comfortably, very easily, move them into buprenorphine, and oh, by the way, they're not going to be at risk of overdose. They're going to have a persistent pain relief that's better. They're going to feel less clouded, and they're going to be on a consistent medication. And you also get to write 2 refills on that, right? That's what we're talking about here is in terms of a sea change. You remember the original echo, the other thing about the original echo, no, this is academic detailing and safe prescribed. What was happening is they had some really good evidence that said cheap drugs for hypertension worked a lot better than these fancy drugs people were selling, but people were being sold these meds, and so they weren't prescribing them. So what we've had going on here in this, we've had this kind of high barrier to therapy with buprenorphine, right? You got to go get your data waiver. You got to spend 8 hours learning about opioid use disorder before you can start prescribing buprenorphine. And then you got to, decide with the DSM-5, does this person have a use disorder or not? Or how about we just switch them into buprenorphine? Okay. And this one here, and this is particularly because those of you who, I know most of you haven't had this class, that's why you have to be here. Buprenorphine is in the past, we had it where we would do office-based inductions. You get them off their opioids for 24 to 72 hours. You bring them in, you start them on buprenorphine. And then during the pandemic, we let them do it at home on Zoom, and we kind of learned that. Now we've got something called microdosing cross tapers. And basically what we do is we just come in on one and out with the other. Does not have to go through withdrawal. And this article, there's a couple different articles rather, they're saying, seriously, we're still making patients, go through this process, and we can microdose them and taper them. With that information involved, let's go through what we can do with somebody. Make sure I'm not going too long. I am going too long. Okay, I apologize. Let's just talk about this. I'll talk about this quickly. So, case number 1, chronic pancreatitis patient, migraine headaches on these medications. What can we do about this patient? I think the concern with this patient is how they're being co-prescribed, right? We don't like sedative hypnotics in combination with opioids in somebody with a use disorder. We don't really like opioids for a young individual with a history of both alcohol use and possibly problems with THC. Buprenorphine can switch that individual, and it'd be very low doses of buprenorphine. This is the microgram dosing of buprenorphine, the kind you can put on a patch, or you can get, and that will be equal analgesic and improve pain relief, and you may be incidentally reducing the risk of some of the other problems reactivating like alcohol or THC. So you can switch into buprenorphine under this instance, and that's probably going to do enough. And at this point in time, then you can begin to work on the sedative hypnotics and what have you. Same answer here with case number 2. This one I think is really particularly important because I've got to get an individual more comfortable, and then they may still have surgery, right? So somebody goes into surgery with, 75 MME of opioids, how are they going to be managed postoperatively? Well, and conversely, what I can do is I can switch this individual into buprenorphine therapy. Now they're on buprenorphine therapy, and they may have enough of a reduction in their pain that now maybe they'll quit smoking and maybe not, but maybe they'll get the relief that they need from, core muscle strengthening with physical therapy because they've already got a 3-level fusion. And what's the chance that a 4th level fusion is going to make a difference, right? This is really helpful in this situation. And if they do have surgery, then when they go into surgery, they're not going to require 100 or 150 MME dose of opioids perioperatively. They're going to change their receptors back to a baseline, so they'll be managed more successfully surgically. The other one about this here, this one's a little bit more challenging because you've got tramadol, which we don't think of as causing respiratory suppression, but we've got problems with the co-prescribing of the three, the muscle relaxant, the tramadol, and the Ativan. In this case, we may have to take a different approach, but we could also answer that question with buprenorphine, because at this point, now we've bought ourselves time where we can work on the benzodiazepines like the questioner had before, because as we know, it often takes a year to get away from benzodiazepines. But if I switch somebody into buprenorphine, I've been able to make a switch and change how they're doing, and all of a sudden, look, they're more stable and they're more lasting. And the reason that buprenorphine works, and you have to understand how it works as a molecule. It's a partial agonist, but it is not a partial analgesic. It's superior in a chronic pain situation in many cases because it's so tightly bound to the receptor. And remind ourselves that when we look at what opioids do for chronic pain, when we look at somebody, for example, a large meta-analysis of how much relief you get with opioids for chronic pain, low back pain and failed back and all that stuff, at very best, some people get 30% improvement. But most of the studies show us that people on opioids chronically with low back pain do worse than people who are not. So there's a very low bar of improvement in analgesic efficacy by changing. And by the way, we're not deprescribing with this. If we can work with our patients, we do this, they select how they do it. And what I mean by that is when you're prescribing in microdose, what we'll do with the patient is we'll start them on buprenorphine at subtherapeutic doses for a very long period of time, because dopamine is more tightly bound to the receptor than other opioids, and it stays there for a long period of time. Its half-life is 33, 35 hours. And you bring it in, and so you slowly dose it up over the course of a few days, and you're filling more and more receptors with the buprenorphine, and they can take their opioids to a point, and then when they finally get to the point where you dose them all the way up, they just stop their opioids because, oh, by the way, it's not doing anything at the receptor anymore. So it's a little bit like just stepping off a dock onto a boat without having to take a big dive and swim to get to it. So that's what we'll be training on next week in ECHO, and that's some of the concepts of this. And you can see we had a discussion earlier. The concept here is we can all be doing this. Todd was making a very important point when he said the vast majority of these patients, all of us can be managing, right? We don't need specialty care. We are able to do it. And we also don't have to sit here and say, I am now going to treat opioid use disorder in my office. I am going to start using Suboxone for people who are on, fentanyl off the street. You don't really have to make that decision, but what you can do is learn how these concepts can help patients with lesser amounts of disease. And then as you build your comfort, all of a sudden you find we can all be managing these other more challenging cases as well. And that's what I think the MAID Act is trying to get at. It's saying there's no hope that the US healthcare system is going to generate enough addiction specialists to manage the fentanyl crisis. But there's enough of us who know how to manage these to prevent it, and we can get people safer, and we can get them, more importantly, managed with respect to their chronic pain. But these are not concepts that we were familiar with in our prior training, and we probably with the data waiver 2000, we stigmatized buprenorphine as a medication, right? You kind of think of it as you would a methadone treatment program where you're in but it's different, and we're getting better benefits with that, and we can all learn to use that and help. All right. Any questions? Ma'am. Yeah. Yes. It's really kind of here's how, and the only thing we really need to know how to microdose, and you'll learn, is understand that you're filling the receptors slowly, and the half-life is very long. So you make slow changes, and once you get to a certain point, and I'll just tell you, kind of it's around 4 milligrams, you kind of start moving in one way or another. So you can get a patient kind of to 4 milligrams, 3 milligrams, and then you have to kind of move away. And we've in our clinic, you can read about it. It's also, if you want to Google it, it's the Bernese method, and it's quite a bit easier than you might anticipate. Good question. Yeah, question is, how do we comment on monoclonals and the research on that with respect to the down regulation of receptors? And that is ongoing. I don't think it's at a point where there's any clinical utility. And I think it probably also speaks to the idea that this is a heterogeneous group of receptors. And so making a difference is going to be challenging. But beyond that, I don't really know. Yeah. Yeah. Are we going there? How do we address THC? We're going to talk about that, right? That'll be an hour. We're going to be talking about that. And the first answer is we don't know. And it's also, not our parents' weed, the high doses and the risks associated with that. But I don't feel I don't demonize it in my clinic. It doesn't mean certainly, you don't fire a patient with cannabis in their UDS while you're doing prescribing. You change how you prescribe maybe, but also I am not, I'm not gonna say, hey, it's a great thing, especially anxiety and PTSD. We know it worsens that, right? We'll talk about that more, but it's a challenge because we don't have enough data, really don't. And when you talk about it to legislators, they figure you're either against them or for them, and then they kind of stop listening because it's been so politicized. Thanks, guys. How about a 10-minute break? Cookies?
All right, why don't we, if it's okay, get started here for the last part. We had talked about doing something today as well, in addition to what we're doing around anxiety and specifically benzodiazepines, because they can be this kind of a new emerging concern. I'm not sure if it's being kind of overemphasized, but we're not going to do that. It will come up in one of the echoes if you're interested in benzodiazepines and management of and use of benzodiazepines, and which have been around for, as you know, a long period of time. I want to go back to something John said earlier that and emphasize one other thing that we had talked about. Buprenorphine's been out a long period of time. I've been prescribing it since 2003. And I will tell you that when you compare buprenorphine to pretty much every other opiate, it is easier to prescribe and it is safer to prescribe. And so it's regulated, or been heavily regulated by the FDA, which has created a lot of fear in people. And it's very unfortunate because it's safe and relatively safe in overdose. It's very hard to die from an overdose of buprenorphine, and it has very few drug interactions. And so don't let the kind of maybe past or what you've heard about it dissuade you if you're interested in prescribing it for either pain or substance, opioid use disorder, or both. The last part of what we're going to talk about today is nicotine and marijuana. And part of the reason that I said this up front, there's really three kind of main areas we can use medicine for: opiates, nicotine, and alcohol. But those are the same three, with the exception of methamphetamine and marijuana, that are widespread in Nebraska, and so especially alcohol and nicotine. 3 million people worldwide die every year as a result of alcohol. I did not mention that earlier. About 90,000 people die as a direct result of alcohol in the United States, year in and year out. So this opiate wave, it's been problematic for the last several years. Alcohol deaths have been going on a long period of time. And we're going to talk about nicotine as well. So to start things off with a little bit of kind of irony, Dr. Bob Smith and Bill Wilson started AA. This is the Bill Wilson, okay? And so he quit using alcohol in 1934, continued to smoke. And despite wearing oxygen, it's what led to his death. And he talks about using LSD after he quit drinking alcohol. So I just think that's kind of unusual. Plus, he was kind of a ladies' man, I guess, for real. And so there was a lot of issues that went along with Bill Wilson. And sometimes people, I think, thought, oh, he went to AA and lived a very clean life and didn't do anything else. And that just was not the case. All right, am I stuck to start off with? This will work. Okay, so we're going to talk about nicotine. And tobacco, and you can see on the left. These are just some pictures. So that's e-pipe. It's an electronic pipe. E-cigarette or e-cigar, excuse me. Vaping devices, and then the old-fashioned combustible clover with the tobacco products. And then there's all kinds of ways to use marijuana now, and we're going to talk about not only vaping and electronic kind of devices, we're also going to talk about the various forms of marijuana. It's not only widespread, but most people probably haven't, and maybe this audience is a little different, understand the nature of what's out there in terms of marijuana and how to use marijuana. It's not the ditchweed of the past or Reggie that sometimes it was called about 15 years ago or 20 years ago. It's greatly changed, and the ways of using it have changed considerably, as well as many states relaxing kind of the ability to use. So we're going to talk about those things I've already mentioned. Let's move on. In the world, there's 1.1 billion smokers. Pretty consistent number. It's gone up a little bit over time as the population has gone up, but that number is pretty consistent. 7.7 million deaths. It's encroaching on 8 million per year. There is consistently in the US close to 500,000 deaths per year as a direct result of, or indirect, secondhand, of tobacco or nicotine related products. As you know, the lobbying organizations are very strong. So if you think about what's really causing the problems from a substance aspect, probably not so much marijuana, although that's leading to some other problems. Opiates are an issue nowhere near what tobacco causes. It's not even in the same discussion. And so I'm saying that because I think it's pretty important to think about the effects of nicotine, whether it's cancers, whether it's head and neck types of cancers or GI cancers or heart and lung kinds of problems. There are enormous problems that are created. So here's the other thing that happens, and it happens with me, it happens, I think, probably with most people, is you think, okay, we're going to talk about alcohol and drugs, but kind of nicotine doesn't seem to fall in that category. We kind of forget the effects of nicotine or the importance of nicotine and the impact. So it could cause, it's an interesting kind of substance because it can cause stimulation, but relaxation at the same time. And obviously the craving part we've talked a little bit about. There was a diagram that John put up. I don't know if you remember, it was on the right-hand side, and I don't have it here in my slides, but I want to run you through that. All addictive substances, with the exception of the serotonergic hallucinogens, which is like LSD, use this pathway I'm going to talk about. And the pathway is when somebody ingests a substance, within the brain, I'm not talking about pain now, I'm just talking about the substance pathways within the central nervous system. There is in the midbrain, in an area called the tegmentum, there is a release of dopamine. So the ventral tegmental area is in the midbrain. Releases dopamine, goes out to an area called the stria terminalis, but more importantly, it goes to the nucleus accumbens, which is a part of the basal forebrain. and I don't expect you to remember all these terms, but I want you to get the idea of what happens here. Within the basal forebrain, that's where we get our euphoria. That's where we get kind of this feels good. It's a part of the striatum as well that's connected there. And then what happens is it goes to the limbic area, and the limbic area sends signals through the insula into the prefrontal cortex. So now we're consciously aware of this feels good. Within the prefrontal cortex, there's a memory that's generated between that and the hippocampus. So when you talk about associations for triggers, people, places, things, and emotions are triggers to reuse. When you have that euphoria or that feels good and associate it with people, places, or things, those are the triggers to want to use again, because this circuit becomes active again. Use, get high, go into a withdrawal state. What happens when we go into withdrawal? We think of the physiology with withdrawal, and people don't like the physical symptoms of withdrawal. But the biggest driver of withdrawal is the dysphoria for most substances. I don't like the feeling of no motivation and sadness and apathy and so on. So somebody uses again, starts to reinforce that circuit. And remember I said very early on, anticipation starts to come on board then. I anticipate the withdrawal, I don't want it, I'm going to use again. Then, what's really a fascinating thing, if you're into this stuff, and you're probably not, but what's really a fascinating thing is that within this circuit, after a period of time, the euphoria dies out. They've gotten to that threshold where they no longer feel euphoric, and people continue to use, not to get high, but because they don't want to feel crappy. They want to prevent the dysphoria. They want to prevent the negative aspects of what the substance has generated. That's the progression along that pattern of use over time. And so it's, I don't like this sort of feeling. It's now I'm trying to prevent that as opposed to capture the euphoria. I mentioned this earlier. What determines addictive potential? How quick it gets in, and the euphoria that it generates are primarily drivers of that. So inhalation and injection are the quickest. In and out the quickest as well. Ingestion comes in slower and lasts longer. What about smoking overall worldwide? The numbers have gone up because the population has gone up, as you see in this slide, okay? But you can see in Africa and some parts of Indonesia, the numbers have gone up. In the US, the percent of smokers has actually gone down. And so if you look at the colors here, here's kind of the lowering, the decrease in the blues, and the yellow onto the red are where areas that have increased. And so you can see in the US the numbers have gone down depending on any one study now. The adult population, it's 12%, 12 to 13%. Overall prevalence, percentage-wise of individuals has gone down, but total numbers, because the population has gone up, total number of smokers has increased. So you heard me say this, it's in a matter of speaking, it's the number one preventable cause of disability. Roughly 480,000 or almost 500,000 year in and year out die, and 300 billion are spent on smoking related illness every year. It's a lot of money, 300 billion. What about income and education? We know that people that have more education and that have more income have lower smoking rates in general. Obviously, there's some folks that have higher education and that higher income that smoke. That's not to say they're not going to smoke, but in general, we know from the studies, those individuals that have a higher degree of education and higher income are less likely to smoke. Smoking, again, like all substances, often starts during that adolescent time period. So 9 out of 10 smokers have begun smoking before the age of 25. And often it's one of the initial drugs that kids are introduced to early on, 12, 13, 14 years, sometimes even younger now. Let's take that point. Across the spectrum, not for every substance, but for most, if an adolescent starts using a substance before the age of 15, their chance of developing a substance use disorder is about 50%, okay? If they start using before the age of 15. Doesn't mean it's going to be persistent or chronic. I think we kind of delineated that a little bit during the alcohol talk. But for them to develop a substance use disorder is pretty high, especially for those that are using, 13, 14, 12. And so that's a great time to do some interventions. It's a great time to think about what can we do to help these kids who are, seeing or treating in clinic, or my family or my grandkids or whoever the case may be, to have those kinds of discussions and modeling, quite frankly. More than 3 million middle and high schoolers are current users of tobacco or of nicotine or a tobacco product. That number is pretty high. That's in 2022. What do they like? And you'll see in the next slide after this, but they like vaping and flavored products now. So they enjoy the flavoring from what's put in e-cigarettes or Juul or vaping products, as opposed to the old combustibles. The exception to that is the menthol, and I have some data on that here in a minute that we'll take a look at. But 80% of the younger people that start smoking prefer to use some flavored product and e-cigarettes as opposed to the combustibles. Okay, let's take a look at this and let's break it down a little bit. The gray, look at the gray bars on here. Okay, those are electronic cigarettes. If you go from your left to right, that's 2012 to 2021, left to right, and you will see the increase in e-cigarette use over time in the last basically 10 years, and the decrease in combustibles or old-fashioned cigarettes in the dark blue. And the medium colored blue or middle bar there represents the use of both. And this is in middle schooler and high school students, again, from 2012 to 2021. So why am I bringing this up? Because we're going to talk in a minute about, do e-cigarettes make a difference in terms of someone being able to stop using, or in what context? Before we get there, let's talk about menthols. Menthols are very common. And in fact, in African Americans or Black smokers, 85% of them use menthols when you look at the data, and leading cause of heart problems and stroke and cancer. If you think about reducing the amount or cutting out, in fact, just doing away with menthols, the estimates say you could save, close to 200,000 lives in the next 40 years, and it would make a huge difference overall. It's a big industry that there's a lot of money that goes into, and 1/3 of all cigarette sales are. What about when we talk about cigarette coming in and its effects, because it affects multiple neurotransmitters? I'm just talking about dopamine here. I'm going to elaborate on the other neurotransmitters and for things for you to think about a little bit. So inhalation and that repetitive kind of movement, hand to mouth sort of thing, and the titration of that are important components. It's important in the sense that when someone says to you, I don't inhale, they're probably getting a little bit in, but there is some truth to that. The effects of nicotine and all the ingredients that are in tobacco, the deeper you inhale, makes sense, right? The more problems it causes. The hotter the burn, the more problems as well. When you're burning that tobacco at a hotter temperature because you're taking a deeper drag on it or deeper puff on it, right? You are creating more kind of toxic ingredients that you're inhaling that are absorbed in a number of tissues. So the absorption is better for alkaline kind of nicotine products. So for example, snuff or nicotine gum even, that's why it's partly effective, is the park and chew method. We'll talk about that. From pipes, it's more alkaline, so you get better absorption. And it doesn't so much go into fat tissues, but it goes into other kinds of tissues. GI tissues, lungs, as you know, spleen, other organs where the products kind of settle and can create problems over time, whether it's loss of outward appearance with turgor and connective tissue and so on, or internally the damage that it causes. Smoking, that inhalation, part of the reason it's so reinforcing, yes, it's in and out quick, but it gets in within 10 to 20 seconds. So here's the old-fashioned combustible. These at this end of where it goes into your mouth here, you know, those plastic filters are biodegradable, but have all kinds of microplastic fibers within them, that there's been concern raised about that as well, in addition to the products that come in, or the tobacco in the cigarette itself, right? So the deeper that you inhale, or the harder that you inhale, and so on, and the greater the burn, the higher the temperature is of these products, and the more problematic issues that arise as a result. Now, I told you I was going to talk about the effects of nicotine on various neurotransmitters. A lot of people like to, they're afraid of, if I quit smoking, I'm going to gain weight, which is truth to that. No doubt. And my metabolism is, going to slow down, because when I'm smoking, it's increasing my metabolism, and I can maintain my weight and so on. So there is some concern that is just around that. We know that nicotine, like that within that cycle or that circuit that I talked about, stimulates various neurotransmitters. So not only does it release or stimulate glutamate, glutamate's again stimulation, has to do with memory and cognition along with acetylcholine. Dopamine is that pleasurable effect. Norepinephrine, it has effects on norepinephrine, that's level of arousal. So people can smoke and say, I'm more alert and I'm more attentive and I can focus better. There's some truth to that. But also then there's some effects on mood modulation through serotonin and serotonergic effects, right? So there's multiple neurotransmitters. The interesting one here is beta endorphin. And so reduction in anxiety and tension. But the other thing, and I'll mention it in a little bit, is it has effects on pain through beta endorphin. And we don't often think of that. And then, so you get the stimulation from glutamate, you get the stimulation from norepinephrine, you get the calming effect, the relaxation response out of this with GABA. So there's multiple neurotransmitters that are affected. Nicotine. How about that reinforcing every 10 to 20 seconds, you get a kind of trying to keep that dopamine up or that euphoria up, and some of the other neurotransmitters. One cigarette, you think of as about 10 puffs or 10 doses. So let's think of somebody who smokes 1 pack per year. That's, over 70,000 doses, if you will. In Nebraska, the average cost fluctuates and depends on the type of cigarettes, but you put them all together, it's about $5.75. You go to New York, it's about $10.50. And so it's not a cheap sort of thing to smoke cigarettes, and you can be spending a lot of money. And that, I bring it up, everybody knows this, but I bring it up as it may be one of the things you can use when you're seeing a patient to say, well, let's take a look at how much you smoke. What are you paying per pack? What does that look like in a week? What does that look like in a month? How much money you're spending in a year? Oh, you've done this 20 years. How much money do you think that is? Maybe a motivator for them to think about or an incentive to help them quit using. Another incentive is that can be used in the office and is looking at some of the products, carbon monoxide as well as cotinine. And cotinine is a longer metabolite, so you can take a look at to see if it's in someone's system. I put this slide in here. Most of you are aware of, byproducts and so on, and maybe to think about ways of monitoring and measuring. But I put it in here for another reason. I put it in here to talk about drug testing and drug screens. I don't think, John, you didn't talk about that earlier, did you? Drug testing and drug screens? Okay, so let me talk about that a little bit. So when you have a patient that has diabetes and you're asking them, you're doing the typical things with them. They have their eye exams and, you're doing their blood work to look at kind of just overall blood work, but you're checking A1C, right? Their long-term control over the last couple, 2-3 months and seeing how they're doing. The A1C, depending on how you deliver the message, shouldn't be meant to feel punitive. They live with that condition 24 hours a day, 7 days a week, 365 days a year. And they don't want to have that, diabetes and have to manage that any more than anybody else would. And if their A1Cs are up and they feel like you're coming down on them or whatever, and dismissing them, or you're not trying hard enough and so on, that's really not going to be helpful. You've heard me say this in a different context. The A1C, though, is not only an indicator, but it gives them a little bit about, all right, this is where you're at. We want you're at 10. What do you think it would do to get for you to get to a 9? What do we need to do to get to a 9? And working with them over time to bring those numbers down, okay? If a drug screen is used as a punitive measure, and when you look at the data and the studies around kind of punishment for addiction, outcomes are not good. Doesn't work. Only thing it does make people feel bad. And so the drug screens that you use can be used for multiple reasons. One is, let's see how you're doing, and if your levels of whatever you're using are coming down, okay? But equally important, and what I often really encourage when I'm seeing someone when they know they're going to have drug tests, because a drug test is an idea of just one other measure to see how you're doing and managing things. I want them to tell me ahead of time before I know the result. I want them to say, you know what? Hey, doc, I slipped. I used. Why? Because they're starting to take responsibility for it. I want them to take responsibility because there's greater incentive for them to do something or manage their status, their condition, as opposed to blaming or making excuses. If they can own it, and you work with them and you stick with them and they feel like you're working with them and you're a part of kind of their care and you care about them, they're going to be more likely to make progress versus if they are, well, your drug screen, was dirty again, right? That sort of thing. It doesn't work very well that way. And so I want them to come to me first over time and for them to say, you know what, I use. And my response is a really important response at that point. Thanks for letting me know. What do you think we should do here? Nothing. I'm in good shape right now. Okay, let's see how it goes. Versus, I don't think what I'm doing is working. Let's figure out kind of how to modify the plan. That gives you an opportunity to talk with them about the next step. So drug testing is very important. And the delivery and your mindset around drug testing is particularly important. The products that are out there in terms of tobacco, I showed you a screen up front. There are a number of species of plants that have tobacco, and it can be delivered in a number of different ways. And it depends on the culture where you're from and your exposure and the age and so on, and it's rapidly shifting. You've heard me say this earlier that if you increase the temperature, the burn, if you will, to have a higher degree of combustion, you will generate carbon monoxide, nitrogen, cyanide, nitrosamines, arsenic, and so on, just to name some of the byproducts. So these are not good things, right? That tobacco-specific nitrosamines cause all kinds of problems, including lung cancer. And that's, I just want you to be aware of that. So when you look at across the spectrum, what's out there? Kids are using these sticks and strips. And there are various degrees of snuff and chewing tobacco and snus and twists and so on. So there's a whole range of things that are out there that especially adolescents may try to hide. Hookah is more common in other cultures. So if you go over to, for example, various places in the Middle East, they use a fair amount of hookah there. Burns at a high temperature. They sit around in groups and may smoke from the water pipe, and they may be playing cards or whatever. So it's it's more of a group thing in that context versus I'm smoking an individual cigarettes. Not to say they're not using cigarettes on top of this, but I just want to show you the picture of it. Juul, as you know, is another very common thing. One pod is the equivalent of 20 cigarettes. 20 cigarettes are in a pack. And so if you're using a pod with Juul, then that's like smoking a pack of cigarettes. All right, so here is what an e-cigarette, the basic, here's a picture of it, broken down into the components. There's a battery here that charges kind of atomizer that heats this up. It's got a heating element in here. You put the liquid in there or the pod, and then this is the mouthpiece right here. And so e-cigarettes not only are used more, but youth who have vaped are 2 to 4 times more common to start smoking cigarettes. So we're not talking about stopping or cessation. We're talking about someone who is vaping or using an e-cigarette as an adolescent is more likely to actually start using combustibles or old-fashioned cigarettes. So when you look at this FDA ban, this is from a recent article, banning kind of if you will, the e-cig use or access or some of the components around it, it was not effective. It did not make a difference. Now, when you look at this was written by Philip Morris in 1981. It says it's important to know as much as possible about teenage smoking patterns and attitudes. Today's teenager is tomorrow's potential regular customer, and the overwhelming majority of smokers first begin to smoke while in their teens. So they knew this, right? The smoking pattern of teenagers are particularly important to Philip Morris. So they were not only studying this group, but they were clearly marketing to this group. And, Philip Morris makes not only Marlboro, they make Juul as well. They're owned by Altria. Huge, huge influence from their lobbying organization. E-cigarettes have generated concern around lung injury as well, right? And that a direct effect in some individuals. There's a group that was studied here, 2,800, and within that group, over time, there was actually reported 68 deaths. So 97% had respiratory problems, 100% had, kind of constitutional symptoms. So fever, chills, weight loss, fatigue, and a number of them, 3/4 of them had GI symptoms. So there is the toxic products that are coming out from e-cigarettes and from vaping. Should not be overlooked. Patient comes into the office. What do you want to do? How do you do a screen to see if they're smoking? That's very reasonable, especially in that 18 to 25-year population. What are your key questions for that group? All right, are you using any substances, alcohol or drugs or cigarettes, right? So, and how much are you using, right? So the pattern of use. And then have you been able to stop? How'd you do that? You quit? And what did you do that worked so that you could stop using, if you will? And then think about some of those other things that I mentioned, because they're going to factor into helping them if there's some interest in stopping. So that's triggers, right? People, places, and things. The signs from a physical exam. I don't think I need to go through, the change in skin and stains and teeth and so on. What if you got an individual who's interested and you're going to either use a nicotine replacement therapy or you're going to use some other medicine, but how do you measure what they're doing short of them telling you? Well, there are devices out there where you can measure carbon monoxide or cotinine and use that as an incentive or a motivator, knowing that they're going to come in. It's kind of like one of the biggest motivators to help people not use substances is random drug tests when you look at that. So I work as an MRO. MRO is a medical review officer to review drug testing and drug screens, right? And I will tell you that when I have to call people up if they're positive, one of the things that I always reinforce to them is, well, you know, you're going to be tested again. And this one had, you know, cocaine in it or whatever the case may be. And that's often enough for them, unless they're really, really kind of having a chronic problem, for them to change their behavior. They don't want to be caught. They don't want to lose their job, especially in a DOT position or DOT sensitive position. You know, they can lose their job. It can result, if you are, have a license in Nebraska, healthcare license, and you are being monitored by your licensing board, you're going to have drug tests. And if that test is positive, meaning if there's something in it that shouldn't be there, and it's under a settlement agreement with your license, that could result in other problems for you. So it can be an incentive, even if you don't like it. People don't like to be tested and so on. But if it serves as a motivator and it's helpful, there's probably some value within it as well. Now, I forgot to mention this morning, or earlier, not this morning, but earlier when we were talking about alcohol, I mentioned George, I got off on a tangent with alcohol and licensing and George Valiant. He wrote a book called The Natural History of Alcoholism. And I want to bring that up because it's not only applicable to alcohol, but other substances. Licensing boards across the state or across the US use the data to determine how long somebody should be in a monitoring program. And it comes from his studies. And it comes from his studies about the natural history of alcoholism. So if you ever wonder, how did Nebraska arrive that I've got to be in a monitoring program, or I have a colleague that's in a monitoring program for X amount of time, it's based on that. And when you're in the monitoring program, you have random drug tests along with some other requirements as well. So I just want you to be aware that monitoring, whether it's CO2 in this case, or cotinine, or drug testing, is not usually meant to serve as a punitive thing or solely. It's meant to be a motivator in many cases. Measuring CO2, right? And levels last for a couple days, and if they go down, that shows a progress, or if you see levels dropping, you can track progress. So it's just one way of doing it. You can buy the devices at the counter if you have someone too, or you can have them as a provider. All right, remember this morning, earlier, I keep saying this morning, earlier I said brief interventions and the healthcare provider saying something to someone is a big deal. When you look at some of the data and this is replicated, if you talk to a patient about their smoking and you stick with it, outcomes are pretty good. But 4 out of 9 individuals that smoke saw a healthcare professional in the past year, and no questions about it, no advice about quitting or discussions around it. It was just not discussed. We're looking at drugs and alcohol, but cigarettes or nicotine does not seem to fall into that category. Many individuals try to quit smoking, and it's hard to quit on their own. But what enhances the ability to smoke or stop smoking is that regular kind of intervention, along with support, along with replacements or treatment therapies. One of the first slides I showed was addictive potential, and harm and so on was the slide to follow. Remember, nicotine was up towards the top for both of those. And so if we want to tackle this issue and make an impact, it is very helpful if you talk to the people that are coming through in your office and discuss it. And then it's not a one and done. You've heard me say that. We're going to stick with this. We're going to work on this over time. We're going to come back to it. How severe, what do we do and how do we determine how severe a problem is, right?
Two quick ways from the Fagerstrom, and I'll show you that in the next slide here. But if you look at this slide, it's kind of busy, but the very severe over here on your left and all the way down to non-daily use. So 40 cigarettes a day. So what are the big things to look at? Number of cigarettes per day, okay? And time to first smoke in the morning. How long does it take from once they got out of bed to have that first cigarette? The shorter the amount of time and the greater the number of cigarettes, the more severe the addiction is. If they're having withdrawal, remember they don't like the withdrawal. We talked about withdrawal, the physical symptoms as well as the mood symptoms. And so you go back to smoking, it's reinforcing, and you'll see high levels of serum cotinine. So you want to hopefully, if you're working with them and implementing treatment, you want to see these numbers gradually come down over time. Okay, so you get the idea. High number of cigarettes, time to first cigarette, right? The withdrawal, all these variables are particularly important. If you just do the screen or Fagerstrom, and you only have time for two parts of it, do number one, okay? And number one is how long before your first cigarette, okay? The second thing, smoking, because those are very powerful indicators in terms of the severity of their problem. So when somebody's smoking and they want to quit or they go into withdrawal, they get irritable and cranky and they're tired and the throat bothers them and so on. Think about what you can do about that. Think about some of those replacement activities and behaviors, and think about helping them to develop a mindset around, you're going to get through this. It's going to be okay. The withdrawal symptoms are going to come and go, but you're going to be able to manage. Hang in there, and let's figure out some strategies that you can use while you're in withdrawal or struggling that'll get you through the withdrawal and move on so that you're not right back to smoking and reinforcing that, right? And so withdrawal symptoms can last a month, and individuals can get depressed and sad and so on. That doesn't mean they have depression. Incidentally, let's talk about that. How do we sort out if somebody's got a psychiatric illness and a substance problem, or if it's just a substance-induced problem, okay? If you know that there's a clear history that separates the two, in other words, there was no substance use and they had a history of depression, then it may be they do have depression. However, let's take alcohol as an example, or you can use nicotine. If someone is depressed after they quit drinking alcohol, and they're depressed after they quit using cigarettes or nicotine, if it's substance-induced, that should resolve in about 4 weeks or by 4 weeks. If it persists, then it's probably separate and independent and requires some form of addressing or intervention, because if it goes untreated, they're going to be more likely to relapse with the substance they're using. So think of that as about a month that you would expect the symptoms to persist, okay? Now, with alcohol, sleep problems, if somebody's been drinking a long period of time, that can persist a long time, sleep problems. So that's something to think about as well. But in general, the depressed mood, the insomnia, the anxiety, the I can't focus, I'm restless, I'm craving, and so on, those symptoms, if they're substance or if they're nicotine induced, last about a month. All right, let's break. Earlier I said that there's a lot of overlap between men and women in terms of shared features with a substance use disorder. There are some predictors of abstinence for both, and obviously lower level of dependence, greater support. Male versus female there's a greater predictor of abstinence, believe it or not. If you can go without smoking for 7 days and manage that, it's a better predictor. Higher education and socioeconomic status as well. For women, they because of mood and anxiety disorders are higher in the adult population for women, it's a little more challenging for them as well with quitting. And when you look at Chantix or varenicline, it tends to work better in women than a nicotine patch does. So think about that. We're going to talk about more treatments here, but I want you to be aware of that the varenicline seems to work better than pretty much anything else for not everyone, but for women in general. You've heard me say a lot today about the brief interventions, and I told you I was going to get to this slide. So ask if you are and refer, or take care of your, address it yourself. Do you use tobacco? Do you use alcohol? How much? What kinds? And so on. How do you feel about quitting? What do you think about that? Okay. Well, I'm thinking about it. Maybe down the road. Okay. Stop the discussion there. When you come in next time, we're going to talk about this. And I want you to put some thought into what seems like a reasonable date for you to start working towards quitting. Sometimes it's overwhelming if you say, what's the quit date? And that's okay for some people. 6 months from now, on January 15th, I'm done. Okay? And then you have to work with them to set up a pattern to do that. But it may be when you come in next time, I want you to bring back to me, if you will, for discussion about what do you think is the starting point and how can we get there? And don't be afraid to encourage them to use family, right? I've had patients do really well when you say, okay, they're smoking a pack a day. Okay. What do you think might work? Well, I want to gradually cut down. Oh, all right. So how about you do 19 a day for a week, 18 a day for a week, and so on. And at the beginning of each day, you have your significant other dole out those cigarettes. You got to make them last all day long. Okay. So they're working with you on this to reduce the amount that you're smoking. So when you get down to that one cigarette, I always tell them, when you get down to that one, don't smoke half of it and throw it away. Put it back. You're going to need it again. Smoke the whole thing when you're getting down to one, and eventually you won't have to smoke the whole thing, but take a couple drags. The other thing is important. Ask them what time, look at their patterns of smoking during the day. I go to have coffee at this time, I go to the lunch at this time, I go outside at this time. Have them take a look at which of those activities they can start to modify so that it's not because smoking is associated with that. What can you do that's different, that's new, that's not associated with smoking? Let's see if we can eliminate one of those activities, whatever it is. What's the cigarette? What are the times during the day when, man, you need a cigarette? Yeah, you just would kill for a cigarette. What are those times, right? And they'll tell you, they'll know in most cases. Well, right when I get up in the morning, right after lunch, whatever the case may be, leave those alone to start with. Go after those later. Go after the easier ones that seem to be more doable. 6-month quit rates, usually around 25% with treatment from this study. You saw a higher number earlier. Now, I want you to pay attention to the yellow here, okay? This has received a lot of attention from some of the companies that make electronic cigarettes and pods and so on. Oh, well, they market it, well, you're going to just quit smoking and or quit using combustibles, the old-fashioned cigarettes, right? So there's 2 different studies here. One on the left is from JAMA 2021. The one on the right is from the New England Journal. Both basically say, if you're interested in reading more detail, that e-cigarettes compared to other means, whether it's nicotine replacement on the right or other mechanisms, do help in terms of helping a certain group of individuals quit smoking, okay? If it's daily routine use. Those that are using intermittently, no. But if somebody has a fairly significant pattern of use and smoking quite a bit, there are some benefits in switching to e-cigarettes and consuming less and progress over time. what are our options for pharmacotherapy? Let's talk about some of these. So before we get into there, here are content of nicotine in various products. So a cigar, 13 milligrams, if you will. If you look at a pack of cigarettes, it's anywhere from 1 to 2 milligrams per cigarette, okay, of nicotine in that. Joule, you know, again, one pod is equal to 200 puffs or a pack of cigarettes, right? So pipes and cigars and mini cigars have more nicotine than cigarettes, if you think of it that way. So you want to take a look at, if you're using a patch, how much are they using? Where are they at? Where are they at with that Fagerstrom? And then where are they at with the content of kind of milligrams of nicotine in there? And the higher the number, the more you're going to need in a patch. So is it okay to use more than more than one patch? Yeah, absolutely. Okay. And there's been lots of studies to look at combining nicotine and what happens with heart and rhythm and cardiovascular status. And those have all turned out to be, it's okay. It seems to be okay. So the amount you want to start with depends on how much they're using to a degree. And then over time, you want to try to taper that patch if you can. How about gum and lozenges, if you will? Both are short acting, right? And the absorption is a little bit different. The lozenges are absorbed a little bit more. You can use these two together, I suppose, if you wanted, but more commonly, they'll be used with a patch. So the lozenge with the patch, or the gum with the patch. And the gum, remember, you chew and park. So you put it in your mouth, you chew a little bit, park it in between your in your cheek, and you let it absorb. You chew a little bit more and let it go, and over time. And you certainly can combine this with other means, and again, greater absorption if there's basic pH. So if you're having acidic drinks, it's going to diminish the absorption, is my point. All right, how about puffers and inhalers and sprays and so on? All come in fairly quick and they're short acting. There's some benefit with these. One of the things people like about the puffers, that's a hand-to-mouth sort of thing. But you don't see many people using these. You'll find more people using the patch and the gum probably, and obviously the e-cigarettes. And you can use any of these with the e-cigarettes. All of them can have kind of varying degrees of side effects, and there's dosing limitations. And so I'm not going to go through those with you. That's but become familiar with that if you're going to use them. Let's talk about Chantix, which now has been pulled, and the generic is available, varenicline. The alpha-4 beta-2 receptors are the main receptors in the brain where nicotine has an effect. So cigarettes or any nicotine product really stimulates these receptors, okay? And so the Chantix or varenicline, in essence, modulates or blocks that receptor partially. And it's a partial agonist, kind of like buprenorphine is partial, right? Partial agonist. So it is very effective for many people that want to quit smoking, and it can be used for an extended period of time. You start with a low dose, 0.5, do that for a few days in 0.5 BID, and then eventually go up to 1 milligram twice a day. Bupropion is an antidepressant. It's a norepinephrine reuptake inhibitor, primarily, and at higher doses works on dopamine and dopamine reuptake. So it blocks the, if you will, some of the rewarding effects of the nicotine, and it can be used indefinitely. Fairly well tolerated by most people. You can, if somebody has depression, you can tackle 2 issues with it if you want. We tend not to combine these two, and I'll talk about that here in a minute. Individuals that have a active eating disorder or a seizure disorder, they should not take that. So what do we do, right? How do we manage some of these conditions? How do we manage some of these treatment options with the possibility we can safely combine them? Well, you can combine nicotine therapies with each other. So you can combine a patch and gum or patch and inhaler or what have you. You can probably combine varenicline with some of the other nicotine replacements. That's a little bit controversial, but it's probably okay. You can combine buprenorphine or Wellbutrin with some of these strategy or with some of the other nicotine replacement methods or strategies as well. The bottom line is if you're going to use one thing that has the greatest impact for the majority of smokers, it's varenicline, okay? And you can put a patch with it, but when you look at the 9 to 12 week interval or longer out to 24 weeks, it's the most effective for people that have psychiatric or non-psychiatric comorbidity. And in other words, they're just smokers with no kind of mental illness. Varenicline is probably the best. And it, like anything, can have side effects. All right, so think of working with these individuals as finding a starting point, these patients finding a starting point, having those conversations with them, and working towards an agreed upon solution where you're going to keep coming back to it. And if you need to monitor, kind of using a device like CO2 or whatever, then feel free to do so. I mentioned before that acute effects of nicotine help pain through beta endorphin. Over time, repetitive use makes pain worse. And in fact, if you look at the group of smokers that continue to smoke, they're more prone to develop an opioid use disorder because the release of various catechol or various neurotransmitters that we've talked about has a dampened effect on opiates. So they need more to get the same relief or same effect. And in needing more to get the same effect, they use higher amounts, and they're more likely to develop a substance problem related to opiates. So smoking related to, John talked earlier about back pain, how common it is. I use that as an example here. Not only is back pain often worse in smokers, but it's worse for a variety of reasons, not just because of diminished bone density, but healing processes from an injury, oxidative stress, reduction in kind of connective tissues and those things that make up connective tissues. All of those things have a detrimental effect on somebody recovering from back pain. And I mentioned this earlier about most studies that cigarettes withdrawal leads to a phase of decreased pain, but then prevalence of smoking and opioid use disorder goes up. So smokers are 5 times more likely than non-smokers to develop an opioid use disorder. So it's pretty common when you think about that. We're going to change gears for the last part of our discussion, and this is largely going to be informational. And I know it may be boring to you, and I appreciate that, but this landscape is really changing with marijuana. And so it's better to, I think, know a little bit, and then you can forget it if you want, or if you're not interested, I understand. So when you take a look at where marijuana comes from, it comes from various places, right? The bottom, the ruderus, comes from mainly parts of Asia and Russia, and some parts of Europe. The indica is in the mountains, and the equatorial sativa is where cannabis comes from. In Nebraska, it's still not legal recreationally or medically as well. So if you look here, right, it comes in a lot of forms. It comes in leaves, and it comes in hashish, and it comes in concentrates, and it comes in candy gummy bears, and so on. Let's talk about some of these a little bit more. It can be vaped as an oil or a wax. You burn it with that heating element, right? And or even a plant bud, old-fashioned, you smoke it in a joint, or you can take, ingest edibles. Concentrate values have gone up. As potency goes up, euphoria goes up. Depending on route of delivery, addiction potential goes up. Okay, so just think of that in terms of what we're going to talk about now. So smoking, there's a lot of ways you can smoke marijuana. joint or rolling it or blunt. You can smoke it through a bong or hookah. You saw the hookah a water pipe earlier. Standard dose from smoking is 1 milligram of marijuana. Hashish, this kind of, looks almost like kind of a brownie or something here. It comes from, part of the concentrated extract in marijuana. And it has psychoactive ingredients, and it's usually smoked, but it can be put in a liquid and vaped as well. 10 milligrams is the standard here of the marijuana content. How about edibles? These are cookies and brownies. These come in slower when you eat them. They last longer. And because it's not regulated, you don't know how much is going to be in. Remember, the things that people are buying or using, largely in other states where it's recreational, contents are not highly regulated or monitored. So you don't know how much is going to come in or what problems you're going to have. Also, again, 10 milligrams with the edibles. How about the concentrates? This is where a lot of things are changing right now. Concentrates of, if you will, marijuana and active ingredients in marijuana. So now we're talking about dab, shatter. We're talking about waxes and so on. And if you look at the picture here, you can see the hash down here at the bottom. But now we're talking about shatter, and I'll show you another picture here, and some of these resins they're burned and smoked, okay? And the standard dose is higher. Some are burned in what's called BHO, butane hash oil, via an extraction process. They pull out, put it in the pipe and burn it. Here's shatter. Shatter, if I was not to show you this here and just show you this picture and say this is a drug, and you weren't familiar with what shatter is, if you've ever seen methamphetamine, tina or glass, okay, if it's got a little bit of impurity, it will look like that, okay? If methamphetamine is pure, it'll look like ice. Okay, so this would be like an ice cube, right? And but it looks very similar. So this is a resin, if you will, or a concentrate, right? That's this color that you break it up into little pieces, and then you burn it and you smoke it, or that's one way you can do it, right? And the concentrates can be 80 or 90%. When I was a kid, ditchweed was 3 to 5% marijuana. Active delta-9 THC, that's the active ingredient in most marijuana, okay? Then along came Reggie. Reggie is about 7 to 10%, right? And now the average, what you'll find on the streets for marijuana across the spectrum is about 14%. So it's gone up. This, 80 to 90%. You smoke it, so you're inhaling it, comes in quick, causes that euphoria, okay? Addictive potential is much higher. So when we talk about addiction from marijuana, and people say, how addictive is marijuana? I say it depends. Because it depends on the potency and the route of delivery. Now, there's all these synthetics too. So you've got the spice and K2s and so on that are manufactured in labs that are sprayed with herbal incense that people smoke. And these things can be incredibly toxic, not just because of the ingredients. You can see the potpourri that's here, but the spray that goes on them, those chemicals can be, it's like sometimes like putting hairspray and then smoking it sort of deal. And so it can be very dangerous and cause brain damage. So you think of one of the most common problems on Native American reservations in the adolescent population is use of inhalants, okay? And inhalants at that stage are very toxic to the central nervous system. And those kids that are using them not only can develop an addiction, but their cognitive horsepower diminishes over time. In other words, their intellect diminishes, their IQ, their ability to regulate their emotions, their regulation of their impulse control. Those things all go down with use of inhalants. Same sort of process can happen when we're talking about some of the synthetics. You probably, maybe you haven't, but what's happening now is that there are people switching the types of marijuana they're using to try to get around either a drug test or what have you. So Delta-9 is the active ingredient in traditional marijuana. Now you're shifting that double bond to go to Delta-8 or Delta-10. Neither are quite as potent, but they do have psychoactive effects, and they can become habit forming, they can become impairing. There's a whole other kind of development with over at the right where you see HHC, hexahydrocannabinoid. There's being tested for insomnia and pain. If you go down to the THCP, so that's tetrahydrocannabiforanol, it is really potent from the early studies, and not only really potent, but it creates anxiety and paranoia. And this is setting the stage for me to talk about something else here in a little bit. Then if you get to the THC, the O-acetate, there's some early studies that say this is like using LSD. Okay, you remember LSD is a serotonergic hallucinogen. So it's a serotonin agonist, but it's a hallucinogen. Okay, so you get the idea that other things are developing here, and I just want you to be aware of that. I don't want you to get caught up in all of this. So how about CBD, right? CBD in the Farmer Act Bill of 2018 says that you can sell CBD if the THC content is less than 0.3%. So 0.3%. It can be sold as CBD. CBD interacts with both, it's an agonist at both CB1 and CB2 receptors. You say, well, what difference does that make? We have an endocannabinoid system in our body. So we have an intrinsic, an internal system that's in essence kind of our own marijuana system in a crude way of thinking about it. We have these receptors that are CB1, which are mainly in the nervous system. And I'll talk about that a little more here. And CB2 is mainly in the periphery, tied to the immune system. And so CBD is not only indicated now and has an indication for a few forms of childhood epilepsy, but there are studies ongoing to look, does it have an effect on pain? And if so, one of the things I've been fortunate to do is work with a number of athletes through the years. And I will tell you that in the various sports at higher levels, you will find the acceptance of using marijuana and marijuana-related products. And the owners and the leagues and so on, they don't really do much about it. In fact, if you look at the IOC, the International Olympic Committee, they've changed their cutoff level for a positive test now from 50, which is the standard for a screening test for the DOT, the Department of Transportation. So if you're a truck driver, if you're driving boats or whatever, it's 50. The IOC gone to 150. So you're not testing positive if you are at 150. I'm sorry, below 150. It's a negative test, and that you will find a number of athletes that will say, I use marijuana and I use it, and especially hockey players, for example. I use it because I recover quicker. Now, remember that sport, they're going out and getting beat up pretty bad. I recover quicker, it helps my pain, and I sleep better. And you'll hear that very, very commonly. We don't have great studies to show that at this point in time, other than what we're hearing from kind of some athletes and others that would say the same thing. I'm using that as an example. So how about, what do we know about marijuana and some of the benefits, and whether it's being used as Marinol, which is the active ingredient in Dronabinol, or whether it's being used in as Nabilone or whatever. There is some that helps with intraocular pressure or glaucoma, wasting syndromes, whether it's due to AIDS or other kinds of things. Epilepsy I've talked about. And I think there's some benefit in the chronic pain as well. And these things are fairly well documented, as well as the nausea that goes with that. How far it goes in terms of, does it help with acute pain? Some patients will tell you there's not robust studies to show that. Does marijuana help manage PTSD? The data is not real robust, but there is some indication that it may help with some of the psychiatric kinds of conditions. I certainly wouldn't use it as, I'd exhaust everything else before I'd think about that. So, all right, onset of action. When you smoke it, it comes in fairly quick, right? Within seconds, lasts 1 to 3 hours. When you eat it, it comes in about a half hour and lasts, anywhere from a half hour to a couple hours and lasts anywhere from about 4 to 10 hours. What about these CB1 receptors? Well, here we're back to that whole circuit I'm talking about. And prefrontal cortex is involved at the last stage of this decision-making after the tone is set for euphoria and emotions and emotional regulation. And now when you get to the prefrontal cortex, there's impairments, right? So we know someone that, and when you look at the studies over a period of time, and there's been a couple longitudinal studies, on average, somebody who's a regular routine user that starts in adolescence will lose 8 IQ points from the studies, okay? That takes you out of kind of the normal range of IQ and puts you into the lower range, if you will. So that can be important. It interferes with impulse control, emotional regulation, psychomotor speed. So if you, let's go back to the athlete. If they're smoking a lot of marijuana, or even a fair amount, it's going to interfere with their reaction time. It's going to interfere with their coordination. It's going to interfere with their ability to learn if they need to learn in the classroom or, you know, anybody in that context. So there are problematic issues that arise not only from movement, but cognitive things as well. Short-term effects, I think everybody knows these, you know, it's kind of not necessarily synesthesias, but certainly altering perceptions, and time slows down, you get the munchies, you're relaxed, your anxiety dissipates or improves, you feel good, right? You enjoy that state that you're in. Certainly can vape, whether it's an oil or another means, and we've talked about that. I just want to give that as a reminder. Let's talk about this in a little more detail. The adverse effects besides the fine motor control and coordination, reaction time, and learning and memory. Let's dig a little bit deeper. We know that there are 3 times in which the brain really develops, more so than others. Remember, our brain never quits developing. We go through developmental phases from when, you know, in utero all the way to the end of life, and that's changes not only that are influenced by our ability to do things or manage things, but also learning tasks along the way. One of the most difficult things we learn from that aspect is to walk. There are neuroscientists that will tell you the major function, and it's hard to refute this, the major function of the brain is movement, right? And so when you impair movement, whether it's eating, driving, walking, whatever the case may be, during developmental times in utero, terrible twos, 18 to 36 months, they're usually not going to be smoking weed or anything during that time. But that third time is adolescence. 12 to 25 is what I'm talking about. When you interfere with circuit connections, neuronal development, glial cell formation, and all the things that glial cells do within our nervous system, you can end up with not only learning and memory problems and emotional regulation and disinhibition, inability to control my impulses. But the other thing that happens is there's a greater propensity to develop a psychiatric illness that can be difficult to treat, whether it's anxiety or depression or psychotic symptoms. Certainly more prone to accidents in general, and you know about some of the other things that I've already mentioned. More likely to go in the ER, especially with higher potent materials. How about the cognitive effects? Can't think as quickly, thoughts don't come as clear, my memory's not as good, my judgment's not as good. Can't seem to glean information to put things together or tie them together. All those things happen. can't, tension goes down, concentration goes down, all of these things. I can't hang on to something and apply it or manipulate it. You've heard me say this. So all of those things are much more pronounced, especially if used during adolescence. Now, this is the slide I'm leading up to. As potency goes up, addiction potential goes up. As potency goes up, psychiatric illness goes up. As potency goes up, cognitive horsepower goes down. So when I say psychiatric illness goes up, in particular, there's a fair amount of data now to suggest that when you're using higher potent marijuana, especially in males, their likelihood of developing psychotic symptoms from daily use during adolescence goes up to around 20%. And subclinical symptoms, the numbers are much higher, whether it's hallucinations or paranoia. You say, okay, no big deal. And it may not be. It may be a substance-induced psychosis. The more episodes of substance-induced psychosis that you have, the greater likelihood that you're going to develop a psychotic disorder, even if you never use marijuana again. And those numbers are going up. And so we don't know where we're going with that, but it is happening. And it's happening more and more as potency is going up. And this is basically what that slide says, that risk of developing psychotic disorders by frequency of use, type of use, percent of marijuana goes up. And so it's just a summary slide here with another study that complements this study here from Bechtold. All right, cyclic vomiting syndrome. How many of you have heard of that? I got some of you. Good. That's good, because it was unknown for a long period of time. So this is a syndrome that if you have a patient that comes in to you, especially an adolescent or younger person that comes in and they're complaining of abdominal pain and you can't seem to figure out what's going on, and they say, well, I use a heating pad on my stomach and it makes it feel better, or I get in a warm shower and it makes it feel better, start thinking of marijuana. Because that's the way they'll present. Abdominal pain, nausea, vomiting, cramps. They want that heating. Sorry. They want to get in the shower. And so, and the what happens commonly is they will really struggle with the abdominal pain, especially if it gets bad or it's fairly severe to begin with, and they have a lot of nausea and vomiting. They'll go right back to smoking because that'll relieve it as well. They'll go right back to using marijuana. They'll go right back to vaping, whatever it is. And so they're caught in that cycle, if you will. And I've had some people hospitalized for this, and you try to treat it with, antiemetics and Zyprexa. There's some data that may help a little bit, but nothing thus far is really working great as far as I know. There may be some changes with that, or maybe some of you have discovered something that is effective. What about withdrawal? Cannabis does have a withdrawal syndrome. We didn't used to think either nicotine or cannabis had much of a withdrawal. And when you break it down over 15 days, the sleep problems start early on, and focus is off, and people get anxious, and they start to crave and get headaches and sweat and so on. So they get physical symptoms, they get emotional symptoms, and it can last for a couple of weeks or longer. And so just know that it'll go away, but it is often a trigger to start using again. They don't remember that negative tone, that hedonic tone or emotional tone. They don't like that, so they want to use again. What about adolescents? Do most of them use marijuana? No. They're more likely to use if their friends are using or hanging with their friends. And so these numbers are pretty similar in terms of the numbers that use marijuana and the numbers that are vaping. are using e-cigarettes, just under 30%. And so I just want to put that up as a reminder that most kids do not. There's protective factors, parents, religion, commitment not to use, those sorts of things. Use of marijuana in the US, as things have become more lax, has gone up from 2009 to 2021. These are the number of people that have used marijuana in the past year. So again, that number has gradually climbed as many states have allowed recreational or medicinal use for marijuana. We are at the getting close to the very end here. So do we have any great strategies to treat marijuana? The behavioral treatments are the treatment of choice, so whether that's motivational treatment or cognitive behavioral treatment or contingency management, those are the kind of things involving the family and persistence over time with routine drug screens and monitoring over time. Marijuana with multiple uses stays in the drugs, stays in the system for a long period of time. There are some individuals that if you use N-acetylcysteine, it will cut down the cravings, it will cut down the use, and it can be an aid to helping them stopping or at least reducing their use while they're trying to apply some of the behavioral strategies. Neurontin or gabapentin is used in some cases to help with the withdrawal symptoms. There's some evidence at 1,200 milligrams that may help with craving, and if you keep them coming in during that time, it's probably more important than anything as opposed to not following up. There's no FDA indication for medicines at this point for marijuana use disorder. Rimonabant was on the market, maybe 10, 15 years ago as an antagonist. It was pulled because of kind of some side effects and major concerns. There is some medications in development right now. I listed one here that's in phase 2. It's certainly a ways away from being released for treatment. So John and I thank you for being here today. Do you have questions comments for either one of us about anything we have covered? Yes, sir.
In regard to marijuana and cigarettes, and
14 joints of marijuana per day. So I don't know if everybody heard that, but the doctor here is referencing the glaucoma and the number of joints of marijuana being used per day. Those were probably lower potent joints. Who knows, right? The marijuana content, but that's a lot of marijuana. That's yeah. That's not very helpful as well. Yeah, thank you. Yes. Other comments or questions or feedback? If you need more hours, please feel free to join the echoes. You can get them that way. We have recorded previous sessions of things more directly related to opioid use and buprenorphine, and so feel free to access those as well. Thank you very much for coming. Take care.